workshops and CMEs are going to be repeated so that you guys get more exposure and expertise in it. So we are going to start today's program, and we have got lined up initially starting from assessment of airway, to all the topics which are going to become. And for the first lecture of the day, I invite Dr. Kalpana Verma, Professor of Anaesthesiology, to deliver her lecture on airway management, assessment of airway.
Good morning, respected Avnish sir, Ravindra sir, my colleagues and students. Thank you so much, sir, for giving me this opportunity. And to start with the airway management, first of all, we are going to talk about clinical assessment of airway. So, what is an airway? Anybody? What is an airway? Siddharth?
Airway is like from external air to
Yes.
pharynx, trachea.
The passes through which the air goes through, and when we do respiration. Okay, so it starts with nasal opening and oral being oropharynx, nasopharynx, and then larynx, trachea, and the division of trachea up to alveoli. So it is the airway. So why airway is important for an anesthesiologist? Why? Because before, if you are going to do a clinical assessment before surgery, then you can avoid unanticipated difficult areas. Okay, there are difficult areas, but if it is anticipated, then you can plan beforehand and manage the difficult areas. So what is difficult airway? There should be a definition or something. So the ASIS defines, American Society of Anesthesiologists defines difficult airways existing if conventionally trained anesthesiologist cannot ventilate or he experiences difficulty in maintaining oxygenation. Okay, then or intubation. So there are two things: ventilation and oxygenation, then laryngoscopy and intubation. If a conventionally trained anesthesiologist is experiencing difficulty in these two areas, then we will label it as difficult airway. Okay. So why airway assessment is important? Because if you know beforehand, then you can plan and be prepared for the difficulty. So our aim should be to prepare for these two areas: ventilation and oxygenation, and laryngoscopy and intubation. Okay. So ventilation and oxygenation includes bag mask ventilation and ventilation through the supraglottic airway devices. Okay. So, because failed laryngoscopy or intubation is not inherently dangerous if you can oxygenate the patient. So, if you can ventilate through bag mask ventilation or supraglottic airway devices, then your patient would survive. Okay, so don't stress on intubation or laryngoscopy or intubation too much if you are able to ventilate through bag mask or supraglottic airway devices. So, what should be a difficult bag mask ventilation? How will you assess the adequacy of bag mask ventilation? If you are able to maintain the oxygen saturation and it is confirmed by end-tidal CO2 determination, then it is difficult bag mask ventilation if there is inadequate mask seal, or there is excessive leak through the bag mask ventilation, or there is excessive resistance to ingress or egress of gases. Then it is difficult bag mask ventilation. So, what is difficult laryngoscopy? if it is not possible to visualize any part of glottis, okay, any part of glottis, vocal cords or posterior commissure or anything, if you are not able to visualize it after repeated or multiple attempts, then it is labeled as difficult laryngoscopy. So what should be a difficult intubation or failed intubation? Difficult intubation if intubation requires multiple attempts, and failed intubation if you are not able to intubate even after multiple attempts. Okay? So then you should also know about difficult supraglottic airway ventilation. Okay, it can also be difficult at times. So what can be the causes if the supraglottic airway device was very difficult to insert with? Okay, first of all, then there is inadequate seal, or there is excessive gas leak, or there is excessive resistance to ingress or egress of the gases. So, can you determine the difficult airways before it? Yes, we already do. Okay, in PSC, what you do? Okay, what is the basics of this airway assessment? What you do in PSC? You will look for difficult back mask ventilation predictors. Okay, so what are these? Yeah, individual indices and the grouped indices. So first of all, as with any other evaluation, you are going to go with history and then examination. So because the best predictor of the future behavior is the past behavior. So we always ask for patient for previous surgery, previous interventions also. Okay. So first of all, go with the history. If patient had any surgery or airway interventions, then take history about it, and you will know that whether there was difficulty during previous intervention or surgery. So, then, or you can take history of OSA also. Okay. Then there can be congenital airway abnormalities also. So these are some syndromes which are associated with difficult airways. Okay, so Down syndrome or Pierre-Robin syndrome, Treacher-Collins syndrome, or Kipple-Field syndrome. So after history, there can be acquired factors also. So if there is burn, facial trauma, infection, or hematoma of the face, or edema, swelling or tumor of the upper airway, ankylosing spondylitis, rheumatoid arthritis, or cervical spine injuries. Okay. Then obesity, diabetes, or pregnancy. These also comes under difficulty. So, what are the predictor of the difficult back mask ventilation? There are individual indices and the group indices. So, in this picture, you can see many individual indices. Can you name any? Obesity, beard, age, short neck, elderly, maybe edentulous, okay, OSA. So, individual indices are presence of beard, obesity, if the patient is having BMI more than 26 kg per meter square, elderly patient over 55 years of age, dental status, they may be irregular, they may be buck teeth or edentulous patients. Snorers, heavy history of OSA, hair burns with some like sick population or yes, and jewelry or facial piercing, which will cause leak during back mask ventilation. So, if we group these multiple predictors, then we can form group indexes. So, first is bones, or you can rearrange it as obese also. So, in bones, bearded individual, obesity, no teeth or edentulous, elderly, and snorers. So, if patient is having more than two of these predictors, then you can label it as difficult back mask ventilation. Then these predictors are rearranged as modes also. So, mask seen may be difficulty in patients having receding mandible or congenital syndromes or facial abnormality or previous burn strictures. Obesity, advanced age, no teeth and snorer. So basically these two are rearranged. Okay. Then can you predict the difficult laryngoscopy also? So can anybody tell me about the steps of the laryngoscopy? How you prepare for a direct laryngoscopy? First of all, position. So after giving pre-medication and we are assuming we are giving pre-medication, induction agent and the muscle relaxant. Then after positioning. So what should be the ideal position for intubation? Direct laryngoscopy, sniffing position. So there should be adequacy of the cervical flexion and the atlanto-occipital joint extension. So keep in mind, because we are going to assess this function in the clinical examination. Then what do you do after positioning? Mouth opening. So inter-incisor distance, protrusion of the mandible, and these or buck teeth or edentulous patient or these. So these factors will affect your insertion of laryngoscope. So then you insert the laryngoscope from the right side of the mouth. Then go look for the base of tongue and shift your tongue to left side. So if you are going to push the tongue into the mandibular space, so there should be adequacy of the mandibular space. It should be compliant enough to accommodate the tongue and the laryngoscope plate also. So we will check for these clinical predictors also. Okay. Then you look for, then after going below, after base of tongue, you look for epiglottis. So then comes the direct visualization of the epiglottis. Then you go, your tip of the laryngoscope will go into vallecula. Then you will lift the epiglottis. So it is for the force you will apply if the mandibular or mental or submental space is not compliant enough, then you will not be able to lift the epiglottis through direct pressure. So then you have to check for these structures also. Then visualization of the glottis is the most important step for intubation. Then if you are looking at the whole picture of the vocal cord or the half part or the posterior commissure, or so we will go for these grading of these views also. Okay. So for difficult laryngoscopy, so these steps you all encounter daily. Okay. So if there is difficulty, then you will use bougie or stylet or all things. Okay. But you should know about the steps of the laryngoscopy. So what clinical predictors are there? So you look for it. So first of all, as with Bergman's ventilation, there are physical examination, radiological indices, and the advanced indices. So for most important are our physical examination indices. So first of all, what we talk about positioning. So you have to assess the cervical and atlanto-occipital joint mobility or its function. So in 1936, Baghel suggested that sniffing position with the cervical flexion and the atlanto-occipital joint extension is a very good position for laryngoscopy, and it puts oral pharyngeal and the laryngeal axis in one line for easy intubation and laryngoscopy. Okay. So in this picture, as you can see, this is the position at bed. Okay. So this is oral axis, this is laryngeal axis, and this is pharyngeal axis. These are not aligned well. Okay. So what will we do? We put a pillow below the neck, below the head. So it will cause cervical flexion. So if you are doing this cervical flexion, it will put these two, pharyngeal and laryngeal axis in more alignment. Then extension at the atlanto-occipital joint will put the oral axis in alignment with pharyngeal and the laryngeal axis. So for this cervical and atlanto-occipital joint flexion and extension to be happen, there should be adequacy of the cervical and atlanto-occipital joints. So how can you assess these joint function? First, you can do direct assessment by extension and flexion. Okay, you ask the patient to do full flexion and extension. Okay, so you can see if there is a deficiency of more than 2/3 this cervical extension, then you can label the patient as difficult varicose. Then again, you can do Gallican test also. It will also assess direct function of the atlanto-occipital and cervical joint. What are you going to do? You are going to put your left finger at the mentum and the right index finger at the posterior, at the lower part of the occiput. Okay. So then ask the patient to extend his neck fully. If your left finger is going above the right finger, then there is adequate cervical atlanto-occipital joint extension and cervical flexion. Okay. So if left finger is higher than right, then it is normal. If in line, then it is difficult. And if after full extension, this finger is lower than the right, then it is very difficult varicosity. Then you can do indirect test also for assessing the atlanto-occipital joint functions. So what can you do? This prayer sign. You ask the patient to approximate the both palms. So if the patient can do it fully, this is normal. Okay? All the interphalangeal joints are touching each other. Okay? So then, if patient is not able to extend his interphalangeal joints and these interphalangeal joints are not touching each other, then it is a positive predictor for difficult laryngoscopy. This test can be done in other form also, palm print test. You apply ink to the palm of the patient and then ask him to press it on a paper against a hard surface, and what palm print you get, then you can decide about atlanto-occipital joint function. So in grade 1, all the interphalangeal joints are looking fine, or prints are there. In grade 2, these 4-5 interphalangeal 4-5 digits there, and these interphalangeal joints are missing. Then 2nd to 5th interphalangeal joints are missing, and in grade 4 only the tip of the digits can be seen. Okay, so these two are going to be very difficult. So what is the hypothesis behind this prayer sign and the palm print sign? Yes. So these two tests are based on the hypothesis that non-enzymatic glycosylation of the proteins will also affect the cervical joint also if it is affecting the peripheral joints. Okay. So higher the score in the palm print test, there will be difficult endoscopy. So then what we did? Mouth opening. Okay. So there should be adequacy of the temporomandibular joint function. Temporomandibular joint does two functions. Like first, relation of the condyle into the synovial cavity, which causes first 2-3 centimeter of mouth opening. Then the forward displacement of the mandible causes further 2-3 centimeter mouth opening. Okay. So how can you check it for interincisor gap? Okay. So what should be the ideal measurement? 3 fingers of the patient. Okay, if patient can insert 3 fingers like this, okay, so it should be adequate. It should count as 5 centimeter, more than 5 centimeter. Or why you need 5 centimeters? Can you do with 2 fingers? Okay. With 2 fingers, you can barely insert your laryngoscope. Okay, or LMA also. Okay, less than 2 fingers will not allow the insertion of LMA also. So this test is also important. So less than 3 centimeters will cause difficult laryngoscopy, and less than 2 centimeters will not allow the insertion of laryngeal mass. Then forward protrusion of mandible is also important for mouth opening. So how will we assess it? Upper lip bite test. You ask the patient to bite his upper lip or this vermilion border. Okay, the border between the skin and the lips. This. Okay. So in grade 1, lower incisors can bite above the vermilion border. Okay. In grade 2, lower incisors up to the vermilion border or less than vermilion border, and in grade 3 he will be unable to bite the upper lip. So it signifies that forward protrusion of the mandible will not be possible, so it will cause a difficulty during laryngoscopy. Okay. Further you can do one more test. Okay, this is the same as you can say, see this mandible is class 1. Lower incisors can be protruded forward to the maxillary incisors. Okay, if patient can protrude his lower incisors forward than the maxillary incisors, then it is grade 1 and it should be ideal. Then if patient is, the lower incisors can be brought at the edge of the upper incisors, that you may encounter some difficulty in this patient. If there is no protrusion or forward protrusion of mandibular teeth from maxillary teeth, then it will cause a significant difficulty during laryngoscopy. So these are for temporomandibular joint function or adequacy of its function. Then we have to insert the laryngoscope, shift the tongue to the mandibular space. So we are going to assess the mandibular space. How will you do it? Thyromental distance and hyomental distance. What is thyromental distance? From where to where? From thyroid cartilage to mentum. In what position?
Extended.
Fully extended and mouth closed. Okay. So this fully extended from thyroid cartilage to mentum with mouth closed. So it should be more than 6.5 centimeters in normal patients. 6 to 6.5 centimeters may encounter some difficulty during laryngoscopy, and if thyromental distance is less than 6 centimeters, then it is going to be difficult laryngoscopy. Same way as hyomental distance, it should be more than 6 centimeters. It is the distance between the mentum and the hyoid. So it should be more than 6 centimeters. If it is between the 4 to 6 centimeters, then it can encounter difficulty, and less than 4 centimeters is going to be impossible for direct laryngoscopy. So then after tongue, your blade is going into the oropharynx. So you should assess for the adequacy of oropharyngeal and oropharynx for intubation and laryngoscopy. So what are you going to do for it? Malam-Batti. Okay. It is the most common test we do in every patient. Okay. So Malam-Batti, can you tell me about the gradings? Who invented it? Who devised Malam-Batti grading?
No. Who will devise Malam-Batti grading?
The name suggests. So, Sir S.R. Malampati, in his original paper in 1985, he demonstrated that
this contribution to airway assessment has been from this country, and Dr. Malampati is an Indian-born anesthesiologist. This index was further modified in initial index, which was propounded by Malampati at 3 grades. This was further modified by Samson India.
so what we do is modified Malampati because Sir Malampati gave only 3 grades. Can you tell me about 3 grades? First grade, Vardhan. Class 1 Malampati is
First grade we see fully glottis and full
Glottis.
full view of uvula.
yes.
And
Then start with
pillars. Then soft palate, hard palate,
Hard palate,
both
then
the
soft
pillar,
palate.
pillars and full view of uvula. Tip of
Uvula,
visible.
then the posterior pharyngeal walls. Okay. So, what will you see in Harsimran in grade 2 of Malampati?
When we are able to see hard palate, soft palate, and some one less than half of the uvula.
Or the, you will say tip of the uvula is masked by the posterior part of the tongue. Okay, you cannot see the tip of the uvula. So, what will be the grade 3? Posterior thinning? Posterior. Ishan. Grade 3 Malampati?
Only hard palate. But uvula will not be able. We will not be able.
You will not be able to see uvula, but will you see soft palate or not? In grade 3, hard palate and soft palate should be visualized. Okay. Then the 4th grade was aided by Samson and Young. So we are doing a modified Malampati score. So this is how you do it. It's done by asking the patient. Okay, preferably in the sitting position and upright position. Ask him to open his mouth as big as he can. Then how will you assess it? Protrude the tongue outside, but without making any noise. Okay. Then where should be your position? Eye level. Okay. You should be at the level of the patient. If you are doing it from side or from below, so then it is not going to be. It is not going to be significant, or it is going to be either from 1 score or 2 score. Okay. Like if you are doing it in supine position, it will deteriorate 1 grade. Okay. If in sitting position you are seeing the 2nd grade, in supine position you will going to see it as grade 3 Malampati. Okay. So if patient is having greater than 2, okay, 1 and 2 are associated with easy laryngoscopy, and these 3 and 4 will be associated with difficult laryngoscopy. Okay. Then, when you are asking the patient to open the mouth, then you can also see for arching of palate. This is normal. Okay, you can differentiate these two. Okay. There is sprouting of teeth and there is narrow high arch palate. So, if it is there, then it will not be able to accommodate the tongue and the laryngoscopy blade also. So, will cause difficulty during laryngoscopy. Then, assessment for this pharyngeal space, you can do quality of glottic viewing during laryngoscopy. So, how can you do it? Glottic viewing. You can do it by 2 methods: indirect laryngoscopy and direct laryngoscopy. In indirect laryngoscopy, as ENT surgeons and all do for their every case, they do indirect laryngoscopy, mirror laryngoscopy. Okay, so they are going to use this indirect method. Okay, this mirror will reflect the viewing of the glottis. So you can classify it is complete viewing of the quads, only the posterior commissure is visible, only the epiglottis is visible, or no glottic structure is visible. Then direct laryngoscopy view, or we say it Cromwell grading. So if it is but awake loop, okay, this is awake loop. Limited direct laryngoscopy is possible if you adequately sedate the patient and counsel the patient. So, or use local spray or lignocaine spray, then you can do direct laryngoscopy. So, it gives the best estimate of the laryngoscopy and intubation, what you are going to encounter. Because if you are viewing the glottis, then you are encountering all the previous factors, okay. You have successfully dealt with the previous factors and you are viewing the glottic opening. So this is the best predictor. So how you classify Cromwell grading? 4 grading. Okay. So original grading was like 1, 2, 3, 4. Okay. So what are these? Gentlemen. First grade.
Full vocal cord visible.
Full vocal cord. What do you mean by full vocal cord? Epiglottis, anterior commissure, epiglottic folds, and posterior commissure also. Okay. What will you see in the second grade? Epiglottis and the posterior commissure. Then in grade 3, only the epiglottis is seen, and in grade 4 you are not going to visualize any part of glottis. Okay, so this is the laryngoscopic view. You are visualizing the complete glottis. Okay, epiglottis, glottic opening, posterior commissure. In this you are seeing only the posterior commissure, epiglottis only, and not even a part of the epiglottis. Okay, so if this and this, okay, in grade 3 and 4, these are going to be difficult laryngoscopy and difficult intubation, and you will also need some aids. Okay, you will need stylet or bougie or bud, okay, to improve the glottic visualization. So then Cook modified this Cromwell grading further, and he divided this second and third into second A and second B, third A and third B. And so what should you visualize? In grade 1, same as the original one, the complete view of the glottis. In grade 2, posterior commissure, part of the glottis. Then in grade 2 only epiglottis and adenoids are visible. In grade 3A, epiglottis only is visualized, but it is liftable. Okay. Then in grade 3B, epiglottis is visualized, but it is not liftable. You cannot manipulate it. And in grade 4, you are not seeing any part of the glottis or epiglottis. Okay. So these are the laryngoscopic view. This is grade 3A. Okay, it is epiglottis is visible and it is liftable. In this, epiglottis is not liftable. Okay. Umesh, what was the Cromwell grading of yesterday's patient?
Ma'am, 3B.
3B.
Not liftable.
We were able to visualize the epiglottis, but we were not able to lift it. Okay. So then comes the Kogo scoring, is the percentage of glottic opening which is seen during direct laryngoscopy. It can be 0 or it can be 100, or partial visualization there 25% or 50%. Then comes sternomental distance. Sternomental distance is an indicator of head and neck mobility, and it has been suggested as the very important and best predictor among the forced protrusion of mandible, interincisor gap, modified Mallampati grading, and halomental distance. Okay, so we are going for full sternomental distance. In full extension, mouth closed, we are going to measure from mentum to the sternum. Okay, so what should be the ideal measurement? should be more than 12.5 centimeters. If it is less than 12.5 centimeter, then it is going to be difficult laryngoscopy. Then we talked about these individual indices. Then we can group these together and form group indices. So very important are Wilson scoring system and the Verma's 11 parameter analysis. Okay. Then Lehman law also you should know. So what predictors are combined in Wilson scoring system? There are 5 predictors. Okay. So what are these? Priya. Name anyone. What are the 5 predictors which are grouped in Wilson scoring system? Name anyone. Rahul? Name anyone. One predictor only. Weight. Very good. Mouth opening. How? You should say mouth opening or you should say inter-incisor gap. Inter-incisor gap. Then 2 are here. And then anyone?
Mobility of head and neck.
Yes, mobility of head and neck. Okay. Then
Retrognathia. Retrognathia.
buck teeth.
Buck teeth and retrognathia.
Retro or prognathes. Okay. So these 5 predictors are grouped together: weight, head and neck movement, jaw movement, which is you are going to be assessed by inter-incisor gap. Okay, and sliding the mandible beyond the maxillary teeth. Then receding mandible and buck teeth. So Wilson grouped these together and gave this scoring. Weight, if it is less than 90 kg, 0, 90 to 110, 1, and more than 100, 2 score was given. For head and neck movement, if it was more than 90 degrees, then 0, up to 90 degree, 1, and less than 90 degree, it is score 2. Then inter-incisor, okay, it is more than 5 centimeter, 5 centimeter or less than 5 centimeter. Then receding mandible, if there is none, moderate or severe. Then buck teeth, if there is none, moderate and severe. So you are going to score this, and if score is less than 5, then it is easy laryngoscopy. 6 to 7 it is difficult, and more than 7 will cause very much difficulty during laryngoscopy. Okay, so you should know about Wilson scoring for sure. Okay. Then Verma's 11 parameter analysis. So what we have talked about, when you start looking, then he grouped these parameters as 4 for tooth, 2 for inside of the mouth. Okay. When you are going to do the Malampati grading, then you can do these 11. Okay. So 2 for inside of the mouth, 2 for mandibular space, and 3 for neck examination. So first is buck tooth, no overriding. So it should be ideal like this. Okay. And if there is buck tooth, so then it will cause difficulty during intubation. Then inter-incisor gap, it should be more than 3 centimeter. Length of the upper incisors less than 1.5 centimeter. It signifies more than 1.5 centimeter there will be buck teeth. And the mandible protrusion test. Mandibular teeth can protrude beyond the maxillary. So these 4 for teeth. Okay. So when you are going to look for Malampati grading, you can ask the patient to, these 3 you can see, and you can ask the patient to protrude the mandible forward and assess it. Then Malampati class cell. So if it is less than 2, then it is favorable. And palate configuration, if it is high arched, then it is going to be difficult, and no arching or narrowness, then it is good for you. Then thyromental distance. Okay. So what should be the thyromental distance? More than 6.5. So you can roughly assess it by 3 fingers. Okay. Then mandibular space compliance by palpation. Okay, this mandibular space you can palpate. Then neck length, if it is short or not. Okay, but it is relative, because if patient is short, the neck is going to be short. But in relative, okay. So if the patient is height is good but neck is short, then you can assess it. Then neck thickness. Okay, if it is more than 40 centimeter, then it is going to be difficult for laryngoscopy. Then head and neck movement, you can ask the patient to flex and extend the neck, so you can assess the normal range of the movement of cervical and Atlantic occipital joint. So these then Arnie simplified score. This also comprises all these 11 parameters only. So okay, and it includes history, previous knowledge of difficult intubation. If it is there, then score of 10 is given. If any pathology is associated with difficult intubation, anatomical or anything, then it is given the score of 5. If there are clinical symptoms, then score of 3. Interincisor gap, then thyromental distance, maximum range of head and neck, Mallampati modified test. Okay. So if this score is more than 11, okay, then you will label it as a difficult laryngoscopy. So if you are in a hurry, you can do simple rapid airway assessment. Okay, it is called 1, 2, 3. What are you going to assess by 1? With one finger you can assess the TMJ, okay, temporomandibular joint function. Put your one finger in front of the tragus, open your mouth. If your finger, if you can feel the sliding movement and your finger can enter this joint, okay, this space, then it is adequate. Then mouth opening, if mouth opening is more than 2 fingers, then it is adequate. And if the thyromental distance is more than 3 fingers, so this is the rapid test you can do. Then okay, it is integrating many factors, many predictors. Okay, so alpha, look externally, look at the patient. If there are difficult back mass ventilation predictors, or if sometimes you can tell like इसका तो difficult होने वाला है, होता है ना? Okay, buck teeth है, or beard, or receding mandible, or arched palate. Okay, so sometimes you can look and say it is going to be difficult. Okay, so look externally. So these may include the following: body habitus, head and neck anatomy, like short neck or thick neck, small mouth opening, protruding teeth. Then evaluate. 3, 3, 2. Okay, this should be higher distance, 3 fingers. Then higher distance, 2 finger, and the 3 fingers mouth opening. Okay. Then Mallampati grade less than 2 is favorable. Then obstruction or obesity. If the patient is having BMI more than 26 kg per meter square, or there is visible obstruction of the upper airway. Okay. Then neck mobility, as we assess with Atlanto-occipital joint function. Then this is lamellar. You can assess the patient. So then comes Sege and Safari test. It includes weight, tongue protrusion, mouth opening, upper incisor length, Mallampati class, and head extension. So all these group indices uses more or less all these: weight, mouth opening, upper incisor length, Mallampati class, and head extension. So these are group. Then intubation difficulty scale. Okay, so this is from N1 to N7. So first is number of additional attempt. Okay, number of additional attempt. I asked for intubation difficulty scoring for the previous yesterday patient. So इसके साथ करो, ठीक है? So N1 is going to be number of attempts. Additional attempt, if there is an additional attempt, then it will going to be additional 1 point. Okay, so we did 3 attempts of laryngoscopy yesterday. Okay, पहले आपने किया and 2 attempt मैंने लिए, तो going to be 2 points, additional 2 points. Okay. Then number of operator 2. Okay. Then Comic Lehan grade was 3B. Okay. So then additional technique like bougie or stillet was used or not. Okay. Then lifting force required. Significant lifting force was required. So it is yes. Required pressure was required, but we were not able to see anything after that also. Then vocal cord mobility, we were not able to see any part of the vocal cord. So what the score comes, then you calculate it. Then if it is 0, then easy. From less than 5, it will be difficult, and more than 5, it is going to be very difficult. Then radiological indices can be done for assessment of the airway. So in X-ray lateral view, occiput not showing properly actually. C1 spinous process distance should be less than 5 cm. Increase in posterior mandible depth should be more than 2.5 cm. And ratio of effective mandibular length to its posterior depth should be less than 3.6, and there should not be any tracheal compression. Okay. So you don't know, then go for this tracheal compression. Okay. So why do we use this lateral neck X-ray? In what cases? Thyroid or mediastinal mass. Or, okay. Then comes CT and MRI. If there is, we know that there is an obstruction, a tumor or floor of mouth, larynx, pharynx, or cervical spine trauma, inflammation, or mediastinal mass or thyroid mass, then you can go for CT or MRI of the airway also. They will give you the measurement of the. Then comes in advanced indices, flow volume loops, acoustic response measurement, ultrasound guided assessment, which we will be talking about, and the flexible bronchoscopy. You can do flexible bronchoscopy and access the air. Then we have talked about difficult bag mask ventilation, laryngoscopy and intubation. Then you should also be able to predict the difficult placement of supraglottic devices. So what can be the factors which will make it difficult? Restricted mouth opening, obstruction of the upper airway, disrupted upper airway after trauma, burn or caustic injection. There can be stiff lung, okay, poor lung or thoracic compliance, and these are the factors for the difficulty placement or ventilation through the supraglottic airway devices. Then there can be predictors for assessing the difficulty creating the surgical airway also is bend, bleeding tendency, agitated patient, neck scarring, and growth or vascular abnormality in the region of the surgical. So we have assessed the difficult bag mask ventilation, laryngoscopy, intubation, supraglottic airway ventilation, and the difficult predictors for surgical airway. So what should be the possible sequence for preoperative airway examination? Now, okay, so ask the patient, please look at me and open your mouth as wide as you can. Stick your tongue out as much as possible without making sound, or don't say ah. Okay, then you can score these Malampati, inspect the tongue size, microglossia, macroglossia, or tonsillar hypertrophy, small mouth, or high arch palate. Then please your mouth, open your mouth again and as much as possible, and insert 2 or 3 fingers of the patient between your teeth, then enter incisor gap, and gently bite the upper lip. Then you can assess the overbite dental status. Okay, then you can ask for upper protrude the mandible and bite the upper lip. Then you can assess the temporomandibular joint mobility and neck protrusion, jaw protrusion. Then you can ask for flexion and extension and assess the neck mobility, and you can measure the hyomental and the sternomental distances. So These are going to be a complete assessment of airways.
So you guys now realize and understand the importance of doing a good pre-operative assessment of airway in order to predict a difficult airway and not to land up in a situation of unanticipated difficult airway where you are not organized and you will end up with mishaps. Now, you have extensively covered on the way it has to be done, and in the end he has given a very comprehensive way of doing clinical assessment, how to do it by looking and then examining the patient systematically. Now it is unfortunate that these things are being taught and these are not being stuck to religiously, and those who are manning the pre-operative clinics, they are possibly not very careful in doing it. And several times she mentioned about one instance which was encountered yesterday only, and it is frequently you get situations where unanticipated difficult airway is there. So if it happens after a good evaluation, it is acceptable. There is a definite incidence of unanticipated difficult airway. However, if it happens because of not being very careful and not following the protocols, then it is not going to be a good commentary on your learning. So, mind you, all of you should carry out all these clinical tests, and whenever there is an ambiguity, then you must consult other colleagues who are senior to you, who can give a comment on it and pass their verdict. And if there is any ambiguity, you can use ultrasound also. We are going to have a workshop today only on use of ultrasound to predict the airway indices, right? And this is a very important area, and this is a good beginning to start the workshop on airway management. And when you predict that it is going to be a difficult airway, you should be clear. So by now you know what is a difficult airway, right? You know the definition, you know various criteria. And now I will invite Dr. Namita Gupta. She is Associate Professor of Anaesthesiology, and she will talk about difficult airway and the algorithms for various difficult airway scenarios. So you have to be clear about those algorithms, right? So, Dr. Namita.
Difficult airway and difficult airway algorithm. Kalpana has told you about the difficult airway, difficult laryngoscopy, difficult intubation. What is definition of difficult airway? Anyone? Difficult airway is a difficult airway when there is an anticipated or unanticipated difficulty or failure by a trained physician or trained anesthesiology in any one of these, one or more of these. One in face mask ventilation, in the laryngoscopy, or there is a ventilation by the supraglottic airway, or tracheal intubation, also in the extubation and in the invasive airway. This is a difficult airway. You can have difficulty in one or more of this. What is difficult face mask ventilation? नहीं, अभी definition नहीं है कि more than 95% you are not able to maintain the saturation and by the end tidal CO2. Mainly आप इसमें देते हैं end tidal CO2 से. It is not possible to provide adequate ventilation, but it is confirmed by the end tidal CO2 because one or more of the following problem. These are the problem: inadequate mass seal. Problem are there: inadequate mass seal or excessive gas leakage or excessive resistance in the ingress or egress of gas. You are not able to provide adequate ventilation, which is confirmed by the ETCO2. What is difficult laryngoscopy? possible to visualize any portion of the vocal cord after multiple attempt of laryngoscopy. This ASA, this is the definition according to ASA. Difficult supraglottic airway ventilation. It is not possible to provide adequate ventilation because one or more of the following problem. What is the problem? Placement difficult हो या फिर it required multiple attempt or inadequate seal हो, excessive gas leakage हो और there is a resistance in the ingress or egress of gas. What is difficult or failed tracheal intubation? It required multiple attempt or it is failed after multiple attempt. What is difficult or failed tracheal extubation? The loss of airway patency or adequate ventilation after removal of the tracheal tube or supraglottic airway device in a patient with a known or suspected difficult airway. Okay? Not tracheal intubation is included, the extubation of supraglottic airway device is also included in this. Difficult or failed invasive airway? Nupur? और ट्रेकियोस्मी होगी ना, मतलब तो ट्रेकियोस्मी होगी, ग्रिकोथेरेपी होगी, क्या होगा? Any anatomical feature or abnormality which reduce the successful placement of airway into the trachea in front of neck axis. Okay? Any anatomical feature or abnormalities which reduce the likelihood of placement of any airway in the front of neck in the trachea. So inadequate ventilation. So we start with the ASA, difficult airway algorithm of adult patient. This is anticipated or unanticipated? एंटिसिपेटेड. हमें मालूम है डिफिकल्ट एयरवे का पेशेंट है, हमने जज कर लिया है बाहर. कल्पना मैम ने आपको सारे इंडिसेस बताई थी. तो पेशेंट कम इन द ओटी. देन डिसीजन of awake intubation or intubation after induction of general anesthesia is yours. Now, is the decision of the clinician who is managing the airway. You can do awake intubation or you can do the intubation after induction of general anesthesia. When you found any difficulty in difficult laryngoscopy or difficult ventilation with face mask or supraglottic airway device, or there is a significant increased risk of aspiration, desaturation or difficult emergency invasive airway, when one or more of these, then you should intubation attempt with the patient is awake. अगर कोई भी difficulty होगी तो when you are not going to give anesthesia ना, तो you will plan awake intubation. If the awake intubation is success, this is okay. If awake intubation is fail, we have to try with other option. What are the other option of awake intubation? We are doing awake intubation with the and other option of awake intubation. You can do awake intubation with the help of video laryngoscope also, or with the lighted intubation aid. Okay. If it is fail, then you can postpone the case because patient is awake. If the no factor is there, you have assessed, there is no difficult laryngoscopy, no difficult intubation, no difficulty in the face mask, no difficulty in the supraglottic airway placement, and patient does not have any risk of aspiration or desaturation or invasive airway assessment managed, then you give anesthesia and induce the patient. And now intubation attempt after induction of general anesthesia. If it is failed, then you have to limit the attempt. What will you do? You see if the mask ventilation is adequate or not. If the mask ventilation is adequate, which is confirmed by the CO2, I have told you. What is the definition of difficult mask ventilation? Difficult mask ventilation is confirmed by the EtCO2. So there is a difficult mask ventilation is confirmed by the EtCO2. Mask ventilation is adequate and is confirmed by the EtCO2. So it is a non-emergent pathway. We are not able to intubate the patient, but we are able to ventilate the patient. We can secure the airway. So this is a non-emergent pathway. Then what will you do? Limit attempt and consider awakening of the patient. Okay, you can consider alternative intubation approach, invasive assess, and other feasibility of options. What is the other intubation approaches? You have tried by the direct laryngoscopy. Now you have tried that the patient, we are not able to intubate the patient, but we are able to face mask or ventilate the patient with the supraglottic airway device. Then we have to try it with the other option. What are the other option? Intubation with the
LMA.
LMA कर सकते हैं और वीडियो लैरिंगोस्कोपी और अदर एड्स इंटरप्रेटिंग स्टीलेट यूज करो, पूजे यूज करो, ठीक है ना? इन सबको यूज करके आप यूज करो. अगर सक्सेस हो जाएगा तो ठीक है. मास वेंटिलेशन इज पॉसिबल ना. वी आर एबल टू वेंटिलेट द पेशेंट बट वी आर नॉट एबल टू इंटुबेट द पेशेंट. If we are failed or condition are deteriorating, then we come in this stage where the mass ventilation is not adequate. We are not able to intubate the patient and also we are not able to ventilate the patient. So we can do supraglottic airway. We have seen that supraglottic airway, we place supraglottic airway, and if the supraglottic airway ventilation is adequate, then it's also a non-emergent pathway. We can do intubation with the supraglottic airway or we can do surgery with the supraglottic airway device. If the supraglottic airway is also not adequate, so there is a condition of can't intubate, can't ventilate. So this is a emergency pathway. So call for help and ready for the invasive assess. We have to attempt alternative intubation approach as by the emergency invasive airway. What is the technique of emergency invasive airway? Needle cricothyroidectomy or cannula cricothyroidectomy or scalpel cricothyroidectomy. If we fail, then emergency invasive airway. What is the emergency invasive airway? Surgical tracheostomy, na? Doesn't take time. Also, the needle cricothyroidectomy doesn't take time. It is also an emergency invasive airway. Mainly the surgical tracheostomy is included in this emergency invasive airway. So what we'll do in the adult patient? We have to judge we are able to ventilate the patient or we are able to do laryngoscopy or intubation, or if there is any risk of aspiration, desaturation or invasive airway access. Then if there is any risk, then you will do awake intubation. Okay? If the awake intubation failed, then you see that we are able to ventilate the patient or not. If we are able to ventilate the patient, we can try the other aids of intubation. If we give anesthesia to the patient, then we have to decide that we are able to ventilate or not. If we are able to ventilate with the face mask or supraglottic airway device, we can continue the case. If we are able to ventilate with the supraglottic airway device, we are then do intubation with the supraglottic airway device, and we are now in the non-emergent pathway. If we are not able to ventilate with the face mask or supraglottic airway device, we are in the emergent pathway, can't ventilate, can't intubate scenario. So we have to do invasive airway access. Now for the pediatric patient, same. Our decision of awake intubation or intubation after induction of general anesthesia is based on the clinician who is managing the airway and experience of the clinician. If there is a suspected difficult laryngoscopy or difficult ventilation with the face mask, then we do awake intubation. We should consider awake intubation, but in the case of pediatric patient, it is not possible to do awake intubation without sedation. Adult में कर सकते हैं, बच्चों में तो नहीं कर पाओगे ना awake intubation. So you should do sedation of the patient, or you can refer the patient to the tertiary care center. If the awake intubation is successful, if it is failed, we can do other option of awake intubation. Other option of awake intubation, मैंने बताया था ना, क्या था? हाँ, वीडियो लैरिंगोस्कोपी, लाइटेड. अरे बार बार बोलो ना, तभी तो याद होगा, नहीं तो सिनेरियो भी याद नहीं होगा. जब यहाँ से जाओ तो पूरा याद करके जाओ. वीडियो लैरिंगोस्कोपी, लाइटेड इंटूबेशन, एड्स हो गया, ठीक है ना. तो दीज आर द अदर ऑप्शन ऑफ अवेक इंटूबेशन. And if you are failed, then postpone the case and terminate the sedation, because patient is awake, you are in the safer side. But if you are given induction of general anesthesia, then you have to assess, then you have to limit attempt and beware of the adequate anesthetic depth, because many conditions are there when you are not able to intubate the patient because of the light plane of anesthesia, or patient is not in the proper plane. So you have to maintain with the adequate anesthetic depth, and you have to assess the oxygenation with the face mask ventilation. In the adult, there are two scenarios. Adequate face mask ventilation is present or not. Emergent pathway or non-emergent pathway. If we are able to ventilate the patient, then it is non-emergent pathway. And if we are not able to ventilate the patient with the supraglottic airway device or the face mask, it is emergent pathway. But in the pediatric patient, there are three scenarios. It is adequate face mask ventilation is confirmed by the CO2, or impossible, or marginal. If it is adequate as confirmed by the CO2, it is a non-emergent pathway. We have to consider emerging of the patient. We have to limit the attempt and be aware of the passage of the time, because time is very important. We have to assess ventilation after each attempt and consider alternative intubation approaches. What are the alternative intubation approaches? You are not able to ventilate the patient with a direct laryngoscopy. Then what will you do? वो तो एलएम में आपने देख लिया ना, आपने एलएम में डाल दिया, आपको पता चल गया इससे कि आपका EtCO2 कंफर्म हो गया. हाँ ठीक है, एलएम के थ्रू आप इंटूबेशन कर सकते हैं. और वीडियो लैरिंगोस्कोप, लाइटेड इंटूबेशन, भाई बार बार बोलो तभी याद होगा, नहीं तो अदर है ना, दिमाग में अदर ही बैठा रहेगा जब तक ये नहीं आएगा कि क्या है. To consider alternative intubation approach or invasive assess or feasibility of other option. Now the face mask ventilation is not possible. So this is the emergent pathway. Can't ventilate, can't intubate scenario. What you do? You make an emergency invasive assess, or you have to make alternative intubation approach by the emergency invasive airway. The third condition is there, where there is a marginal. Face mask ventilation is marginal. To exclude or treat anatomical and functional obstruction and calling for invasive airway assess. And after the exclusion of this obstruction, if you are able to ventilate the patient, that is a non-emergent pathway, and you are not able to ventilate the patient, then it is a emergent pathway. So, in brief, difficult airway algorithm. If you have suspected difficult laryngoscopy or intubation with direct or video laryngoscope, or you have suspected difficult ventilation with a face mask or supraglottic airway device, if you have a significant increased risk of aspiration or increased risk of desaturation, then you go with the awake airway management. If this is not present, then you can do airway management with the induction of anesthesia. In the awake airway management, if the awake technique is failed, then is the awake non-emergence pathway. Because we are able to ventilate the patient and patient is awake, patient is not deteriorating. So we can postpone the case and consider risk and benefit of alternative awake technique, awake elective invasive airway, alternative anesthesia technique. You can give regional anesthesia or any other anesthesia technique. If unstable or can't be postponed, then induction of anesthesia and emergency invasive airway. Okay. And when you give induction of anesthesia and you're not able to intubate the patient after the induction of anesthesia, Review airway management strategies. Pre-oxygenation, okay, you have to assess if the ventilation is adequate or not. You have given general anesthesia, you are not able to intubate the patient. Now your aim is to maintain the ventilation by the face mask technique or by the supraglottic airway device. If the ventilation is adequate, call for help. There's a non-emergence pathway is there. You can use alternative device. You can use invasive airway, or you can awaken the patient. There is a limit of the intubation attempt. This is the 3+1. What is 3+1? Call for help की है ना? 1 by the experienced anesthesiologist and 3 by you. Okay, so now it's a 3+1. So you can use alternative airway device, you can use invasive airway or awaken the patient. And now you are not able to ventilate the patient. So this is a emergent pathway, can't ventilate, can't intubate scenario. What will you do? If face mask ventilation is not possible, then you can go for supraglottic airway or with the tracheal tube. And ventilation also remains inadequate, then emergence invasive airway assess. Or there is also chances of the ECMO or rapid or the rigid bronchoscope. Same with the pediatric patient. If the airway plan is successful, okay, if the oxygenation and ventilation is adequate, if you are able to ventilate the patient, then consider call for help, and these are the devices for intubation of the patient if you are able to ventilate the patient. This is the supraglottic airway device, the video laryngoscope or flexible bronchoscope. You have placed the supraglottic airway device, then you can do intubation with the help of flexible bronchoscope. You are able to ventilate the patient, you have time, then do video laryngoscopy and intubate the patient. You can do surgery, you can ask the surgeon to proceed with the supraglottic airway device. You are able to ventilate the patient. This is a non-emergent pathway. 3+1 attempt are required for this. 3 attempt of you and 1 attempt of experienced anesthesiologist. If you are able to manage the airway, then consider emerging of the patient. If you are not able to ventilate the patient, so this is the emergent pathway, can't ventilate, can't intubate scenario. You can use face mask, tracheal tube or supraglottic airway device, and you are not able to ventilate by all these devices, there is failure. So there is an advanced technique of rigid bronchoscopy, emergency invasive airway and ECMO. And if there is a marginal, in the pediatric patient, these are 3 scenarios. You are able to ventilate the patient with a face mask, or not able to ventilate the patient, or marginal. In the marginal, you are seeing is oxygenation and ventilation is adequate after each attempt or not. If there is an emergent pathway, then go this, and non-emergent pathway, you are able to ventilate, then this is. So the airway management item for anesthesia location. You must have a self-inflating resuscitation bag. You must have suction tubing, suction catheter and appropriate connector, various sizes of face mask, oral and nasal airway, various type of laryngoscope plate and handles, various type of size and type of tracheal tubes, bougie and stillate and emergency airway management tools, various sizes of supraglottic airway, a water-soluble medical lubricant, and all these masks. Now the algorithm of difficult airway society guidelines. We have seen about the algorithm of ASA, which was updated in the 2022. But the algorithm of difficult airway society these are updated in the 2015 only.
In 2015 it was 3 attempts. 3+1 is
22 में तो ASA का ही आया difficult
DS का that is 3+1.
Yes.
In 2015 it was 3 attempts.
So difficult intubation guideline is overview. The plan 1 is the face mask ventilation as tracheal intubation. Plan 2 is the ventilation and oxygenation with supraglottic airway device insertion. In plan 3, face mask ventilation, and plan 3, emergency front of neck access. In the plan 1, if the laryngoscopy is successful, then tracheal intubation, it is failed, then place the supraglottic airway, After placement of the supraglottic airway, you have to consider waking the patient or intubate with the help of supraglottic airway devices, or proceed with the case with the supraglottic airway devices, or with the supraglottic airway device, ask the surgeon to do tracheostomy or you do precothyroidectomy. If the supraglottic airway device is failed, we are not able to ventilate the patient, final attempt at the face mask ventilation. If it is not possible to ventilate the patient, then this is a scenario of can't intubate, can't oxygenate. Then the option is precothyroidectomy or emergency invasive airways. In the first face mask ventilation and tracheal intubation, what is required? Your optimization of the head and neck position, pre-oxygenation is must, adequate neuromuscular blockage, you have to check about the adequate neuromuscular blockage, direct and video laryngoscopy, you can do 3+1 attempt. As the Ravindra boss said, now it is updated as 3+1 attempt. External laryngeal manipulation, what is the external laryngeal manipulation? It is known as the
required hand.
Salis maneuver किस लिए आता है? What is birth? Full form of birth?
Backward, upward, rightward and posterior.
Backward, upward and
Rightward.
क्या होता है सेलिक्स मैनूवर में? कितना प्रेशर लगाते हैं?
इसको posteriorly resolve in respect to you. वो pressure लगता है.
13 किलोग्राम और 13 न्यूटन और 13 पाउंड.
Blanching of fingers 30 Newton.
What is the unit?
Till your fingertips are blanched, it is 30 Newton. Newton.
30 Newton, up to 30 Newton. Na?
Can you quantify it?
Blanching of fingers.
In pounds, you can quantify in pounds. So that you can practice on a some balance कि हाँ कितना pressure लगाना है, opposite side उतना weight रख के pressure लगा के देखोगे, then you be able to identify कि कितना pressure लगाना है.
If you are pleased, you have put required pressure or Salis maneuver, sometimes it is not possible to visualize the glottic structure when you have applied the Salis maneuver or required pressure. If you are not able to intubate, then remove the required pressure and maintain oxygenation. Okay. This is a scenario that you are not able to intubate the patient. You have to declare failed intubation. What will you do? You can use second generation supraglottic airway devices. What is the second generation supraglottic airway devices? आईजेल के अलावा सब मुझे कल से आईजेल ही बता रहे हैं.
LMS Supreme.
LMS Supreme.
PLA Cobra
LMS. Any other than LMA?
Other than LMS?
Combi tube. Or laryngeal tube suction. You can use second generation supraglottic airway device. Why you are preferring second generation supraglottic airway device in this?
Drainage tube है, suction कर सकते हैं.
Drainage tube है और
Wide block.
There are no epiglottic aperture or
you can also intubate. The most important point, you can also intubate by the second generation supraglottic airway device. Okay? You can change the device or change the size. If it's a female patient, you are trying with a number size supraglottic airway device, then you can change the size. You can try with the number 3 supraglottic airway device. Then oxygenation. The most important thing is oxygenation and ventilation. Then you are failed with the supraglottic airway device. What will you do? You will continue with the face mask ventilation. If face mask ventilation is impossible, then final attempt of face mask ventilation by the 2% technique. What is the 2% technique of face mask ventilation?
एक ऐसे पकड़ेगा, एक सीधे.
एक पर्सन दोनों हाथों से मास्क पकड़ेगा और दूसरा बैक पकड़ेगा.
मास्क भी दो लोग पकड़ सकते हैं. That is also true.
Yes.
एक साइड में रहेगा और एक सामने.
एक face.
मास्क भी दो लोग पकड़ सकते हैं.
और क्या कर सकते हैं मास्क वेंटिलेशन में? आपने दोनों हाथों से पकड़ा, मास वेंटिलेशन नहीं हो रहा, फिर
Auspice and nasal and oral airways.
Use your chin.
आप ऐसे
You
पूरा
can put
प्रेशर
your
होता
chin.
है, मास लीक भी होता है, तो यू कैन अप्लाई प्रेशर बाय योर चिन। बैग तो आपने किसी और को दिया, दोनों हाथों से आपने मास पकड़ रखा, यू कैन अप्लाई प्रेशर बाय योर चिन ऑल्सो।
Daily करता है।
So if face mask ventilation is impossible, then final attempt of face mask ventilation and use 2% technique. If you are not able to ventilate the patient by the supraglottic airway device or by the face mask, then it is a can't intubate, can't oxygenate scenario. You have to do scalpel cricothyroidectomy. So there is a condition where there is a call for help and you have to main emergency front of neck access. This is the scalpel cricothyroidectomy is there. What will you do in the case of scalpel cricothyroidectomy? How will you do? How will you palpate the cricothyroid membrane? What is the laryngeal handshake method?
Non-dominant, thing on a larynx and with the thumb and middle finger.
Okay. With the non-dominant hand, we are palpating the laryngeal structure because larynx is a bony structure made up of cartilages and bony structure You, with the non-dominant hand, put your thumb and index finger in the greater cornu of hyoid bone. You are feeling with the greater cornu of hyoid bone. Then palpate it by lateral side-by-side movement. Then goes down. You feel the thyroid lamina by your index and middle finger and the thumb. Now go down. You feel the cricoid. We feel the cricoid with the middle finger and the thumb, and use your index finger to feel the cricothyroid membrane. You have palpate the thyroid lamina. Now you in the cricoid. Use your index finger to palpate the cricothyroid membrane. This is the laryngeal handshake. और उसके अलावा कैसे कर सकते हो? You feel the laryngeal prominence. Laryngeal prominence is Adam's apple. It is in the thyroid cartilage. Then goes down. Feel the ring-like structure signet. It is your cricoid. Between the thyroid and cricoid, there is a cricothyroid membrane. What will you do in the scalpel cricothyroidectomy? If this is a palpable cricothyroid membrane, you have to do a transverse incision. Then and go corded or triplet? Why corded? थायराइड में क्या होता है, इसकी इंजरी हो जाएगी. वोकल कॉर्ड, योर वोकल कॉर्ड से तो आपको वोकल कॉर्ड की इंजरी प्रिवेंट करनी है, सो यू गोइंग कॉर्डेड. ओके, देन you are going with the buji. With the help of scalpel is there and you are introducing buji, and with the help of buji you are now railroading your endotracheal tube of size 6. Then remove the buji and connect your endotracheal tube with the circuit and confirm the right position with the help of EtCO2 and saturation monitor. If you are not able to palpate the cricothyroid membrane, what will you do? You can make a vertical incision, palpate the cricothyroid membrane after the blunt dissection, and now we'll do the transverse incision. Again the transverse incision. Now you are able to palpate the cricothyroid membrane. You have done vertical incision, you have done blunt dissection, and now able to palpate the cricothyroid membrane. Now you are able to palpate the cricothyroid membrane. Do all the step of palpable cricothyroidectomy. Made a transverse incision, go corded, introduce a buji, railroad your endotracheal tube of number 6, and remove the buji and connect with the monitor, connect with the anesthesia machine and confirm with the EtCO2 and oxygenation. So this is a guideline of extubation also. Difficult airways also known as there is a difficult extubation is there. In the difficult extubation, steps are: step 1 is plan extubation, step 2 prepare for extubation, step 3 perform extubation, and step 4 post extubation care. When you plan extubation, you have to assess airway and general risk factor. What is the airway risk factor? Non-difficult airway, any airway deterioration, trauma, bleeding or edema. If there is a restricted airway access, obesity, or there is a risk of aspiration. What is the general risk factor? cardiovascular, neurological, respiratory, metabolic. There should not be hypothermia or hyperthermia. There should not be respiration arrest of the patient. Patient should be awake. Or there is a special surgical requirement or special medical condition should not be there. So if there is no airway and general risk factor, then you have to prepare for the extubation. We have to optimize patient and other factor. How will you optimize the patient? You have to see if there is no tachycardia or bradycardia, no hypertension and hypotension, patient at risk algorithm. You plan, prepare and do. First is the plan extubation, prepare extubation and perform extubation. First plan, assess airway and general risk factor. What is the airway risk factor? Obstruction. And general risk factor? Metabolic, neurological, then okay. If there is no airway and general risk factor, then you should prepare for this. And you have to optimize patient and other factor. What is the patient factor? Then we have to find out if there is a safe to remove the tube or not. If it is safe to remove the tube, then do awake intubation or by intubation with the help of laryngeal mask airway or other technique of airway exchange catheter and other. If it is not safe to extubate the patient, we have to postpone the extubation or we have to do tracheostomy. If there is a low risk are there, low risk algorithm. What is the low risk and at risk algorithm? When the patient in the low risk? And when will the patient in the at risk? Patient factor are there. If the patient factor are there, then patient in the at risk. If the patient in the low risk, then again plan, prepare and perform extubation. In the prepare, you have to select deep or awake extubation. It is a low risk patient. You can do also deep extubation. In the deep extubation is done by the help of advanced technique and in the experienced person and resilience of, and you should check after when the patient is fully awake or not. And in the awake extubation, you can do also awake extubation. Okay. When will you do awake intubation? After the awake intubation? What is the step of awake intubation? Pre-oxidation, suction. There is also a difficult mass ventilation, induction of a difficult mass ventilation algorithm for the pediatric age group from 1 to 8 years. When there is a difficult mass ventilation, you give 100% oxygen and call for help. When there is difficult mass ventilation, step 1 is optimize the head position, step 2 insert oropharyngeal airway, and step C, second line, supraglottic airway device. When there is difficult mass ventilation in the step 1, in the optimization of head position, you've required adequate chin lift and jaw thrust. If the patient, in the pediatric age group, head is large. If the patient age is less than 2 years, you should apply a shoulder pad, shoulder roll. After 2 years of age, neutral head position is sufficient. You have to require, if you have mentioned the cricoid pressure, you are not able to visualize the glottic structure, so you have to adjust the cricoid pressure, and you can do ventilation by the 2 mask technique. Then consult the change. If there is a leak is there, you have to change the circuit mass per connector, and after this, deepening of anesthesia and using the CPAP. If you are inserting an oropharyngeal airway, assess for difficult mass ventilation. If there is a light plane of anesthesia, laryngospasm is there, or if there is a gastric dilatation is there, pass the orogastric tube or nasogastric tube and do after this. If you have applied the second line supraglottic airway device, not more than 3 attempts are required, you can consider the nasopharyngeal airway or release the cricoid pressure. After insertion the supraglottic airway device second generation, if you have achieved the good airway, then continue with the supraglottic airway device. If you have not achieved the good airway, there is two scenario, SpO2 less than 80% or SpO2 more than 80%. If the SpO2 is more than 80%, then you have to consider SpO2 is more than 80%, but you are not able to maintain the good airway. What will the factor? You can change the supraglottic airway device. There is a chances of equipment malfunction. There is a chances of bronchospasm or pneumothorax. You should correct all these factors. If the saturation is less than 80%, then you have to do intubation, attempt intubation and consider the paralysis of the patient. If you succeed, okay, if you are not able to if you are not able to intubate the patient, then you go with the emergency invasive access. This is unanticipated difficult tracheal intubation guideline for children aged 1 to 8 years. Previous one for the difficult mass ventilation and it is for difficult intubation. Step 1, initial tracheal intubation plan where the mass ventilation is satisfactory. Second, the second tracheal intubation plan and this. When you are doing initial tracheal intubation plan, in the direct laryngoscopy, not more than 4 attempts, you have to check for the neck flexion and head extension, for the laryngoscopic technique, for the external laryngeal manipulation, and for the vocal cords, you have to check the vocal cords is open or not. If pure view is there, you have to use Bougie, straight blade laryngoscope and other thing. If you succeed, then do tracheal intubation. If your intubation is failed, but oxygenation is good, you can plan with the secondary tracheal intubation. You can use supraglottic airway device. You can oxygenate and ventilate the patient. You can change the size of the supraglottic airway device. If you succeed, then you can modify your anesthesia plan, or you can do surgery with the supraglottic airway device, or you can intubate with the supraglottic airway device. And if you not succeed, then one attempt of fiber optic intubation with the supraglottic airway device and do. And if there is a failed oxygenation with the supraglottic airway device, SpO2 is falling, when the FiO2 is 1, then convert to face mask, optimize the head position, oxygenate and ventilate. Ventilate using 2% back technique. You can apply CPAP or manage gastric dilatation with the orogastric or nasogastric tube, and you can use non-decolonizing relaxant. When you succeed, then do postpone the surgery or wake up the patient. And if you are failed, not able to oxygenate, then go to the scenario of can't ventilate, can't intubate. This is a master algorithm of obstetric general anesthesia in OBS patient when you are failed tracheal intubation. If the safe obstetric general anesthesia is there are 3 algorithms: safe obstetric general anesthesia, number 2 is obstetric failed tracheal intubation, and number 3 is can't intubate, can't ventilate. In the pre-induction planning and preparation, there is a team discussion. We should do rapid sequence induction. We have to consider face mask ventilation, and face mask ventilation with a P maximum of 20 centimeter of water. Why should not be given airway pressure more than 20 centimeter of water in the OBS patient? Increased risk of aspiration, because they are considered as a full stomach. So there is increased risk of aspiration. We can do maximum 2 attempts of laryngoscopy, 3 attempts by the experienced colleague. In the adult patient, we are using 3 plus 1 attempt, 3 attempts by us and 1 attempt by the experienced person. But in the obstetric algorithm, there is 2 by us and 1 by the experienced person. If we fail in this, then there is obstetric failed tracheal intubation. We are not able to intubate the patient, but we are able to ventilate the patient. So we have to declare failed intubation, call for help, maintain the oxygenation, and we can apply the supraglottic airway devices maximum 2 attempts. Now there is a condition where we are not able to intubate and not able to ventilate the patient. So we can declare it is a can't intubate, can't oxygenate algorithm. We give 100% oxygen. We have to exclude laryngospasm, or we have to ensure neuromuscular blockage. If there is a laryngospasm there, we are not able to ventilate the patient also. So we have to exclude this, and we have to ensure the neuromuscular blockage with the Long acting neuromuscular blocking agent or short acting? With the help of scoline. You can remove the laryngospasm with the help of scoline also, and you can make the front of neck access also. So there is the algorithm of first safe obstetric general anesthesia. There is a 3 scenario with the safe obstetric general anesthesia. Second one is failed tracheal intubation, and third one is can't ventilate, can't intubate scenario. If there is a safe obstetric general anesthesia, there is a pre-theatre preparation and plan with the team are there. In pre-theatre preparation, airway assessment, fasting status, antacid prophylaxis, and we have to check if the intrauterine fetal resuscitation is appropriate or not. We have to do rapid sequence induction. For the rapid sequence induction, check airway equipment, suction, IVSS, optimize the head and neck position, ramping, and we have to take care of the left uterine displacement. Pre-oxygenation, required pressure, and if there is a rapid sequence induction, we have to do first intubation attempt. If it is failed, then second intubation. In the first intubation attempt, if it is failed, we have to check with the patient we are able to ventilate with the face mask or not. If we are able to ventilate with the face mask, then it's a verified successful tracheal. Then we have to try with the tracheal intubation, and then it is tracheal intubation is done. If we are not able to intubate after first attempt, we have to try with the second attempt and third attempt. In between the first and second attempt, if we are able to intubate, then this is known as the successful tracheal intubation. In after 3 attempts, we are not able to intubate the patient, we have to follow algorithm of obstructed failed tracheal intubation. This is the failed tracheal intubation algorithm. Our priority is to maintain oxygenation and ventilation. We can use supraglottic airway device, or we can use face mask or oropharyngeal airway. In the supraglottic airway device, I have told you we have to use second generation supraglottic airway device. If we are not able to intubate the patient, there is a chances of we are placing required pressure. Required pressure is placing for the rapid sequence induction, and because of the required pressure, we are not able to visualize any glottic structure. So you have to remove the required pressure at the time of intubation. If we are able to ventilate the patient with the supraglottic airway device or with the face mask, so it is a non-emergent pathway. We can save. We have to find out it is essential or it is safe to proceed with the supraglottic airway devices. You can proceed with the surgery. And if we are not able to oxygenate the patient with the supraglottic airway device or the face mask, then we have to declare can't intubate, can't ventilate scenario. This is the third algorithm, can't intubate and can't oxygenate. We have to do front of neck procedure. And after front of neck procedure, oxygenation is restored. Then
this will be covered in subsequent. So guys, you may realize that you have to, when you are handling the airway, you have to realize and decide that it is a difficult airway scenario which was not predicted earlier. In order to manage airway in such a situation safely, you have to have clear knowledge about difficult airway and difficult airway management and all algorithms which he has detailed for different scenarios for adult as well as pediatric patient and special situations like pregnancy and obese patients. So you have to be clear about it. You have to know about it. Your entire team has to be familiar about it. They have to know their roles, and they have to have a comprehensive and complete difficult airway card at their head. Mind you, while managing airway, you should not make it an issue of prestige. Particularly, my message is to trainee postgraduates that once they have done a couple of incubations or they have spent 6 months in residency, they tend to think that I have mastered this art. Remember, you can always have a difficult, unanticipated scenario in your life, and patient's life is more important, and therefore never make it an issue of prestige and go by the book, right? So that is why these trainings have been instituted. suited and organized for you. And इज्जत का सवाल इसमें नहीं है कि मैं एक बार में करूं या नहीं, या सक्सेसफुल होता हूं या नहीं होता हूं, और आपकी इज्जत तभी बचेगी जब पेशेंट बचेगा. So remember, any misadventure of this kind can lead to a situation of no return, and therefore these algorithms are extremely important. Now I'll invite Dr. Kaushal Singh Baghel for his presentation on laryngeal mask airway and placement of supraglottic airway devices. Now you know that placement of SGA is an important point in the management of difficult airway. It has been extensively covered in his first part of lecture where supraglottic airway devices have been covered, and now he will talk about in very brief second generation and advanced airways. And I would request Dr. Kaushal to speak only on the relevant practical points which can be useful in this workshop. And I'll also request other speakers who are going to come to stick to the time limit, and their presentation should be more practical oriented as per the workshop, and more details we can always discuss in subsequent field lectures.
Good afternoon, everyone. My sincere thanks to Dr. Avnish sir to giving us the opportunity to share our knowledge to be the postgraduate students. Now today's time constraint is there, so we are very brief our previous lecture which I delivered some days ago. So we are not going to too deep in the theory part, we are just discussing the practical part. In previous class we discussed about the introduction, history and all. We are not going too deep into the theory part. Just to brief, he is Mr. Dr. Archie Bain. He developed LMA in 1981 and commercially available in 1988. Just to brief. Classification, just we discussed previously, based on what are the first generation devices. Anyone? What is the difference between first and second generation? The drawback of first generation, which is improved in second generation, because first generation has no rescue channels. It's not going to prevent aspiration. It doesn't have any gastric channel to aspirate gastric fluids. So in second generation, we design a gastric channel separately to even a full stomach patient, or can be we can put LMAs in full stomach patient also. Yeah? The second generations are Procil LMA, Supreme, laryngeal tube suction, iGel, Sleepa and AirQ. Yeah. Third generation, it's more advanced, it's cuffless, it has two drain tubes, its bowel is become more small, and like Baska mask, it is I think not available in India, it's only used in European countries now. And in based on sealing mechanism, I discussed this previously, so I skip this. Based of lumen, there is some single lumen devices. There is a double lumen devices like Procil, LMAs, combi tubes, and triple lumen Alicia device. Yeah? Indications, I skip this. Contraindication, as we discussed, our senior colleagues, if we cannot open mouth, complete airway obstruction, we cannot use supraglottic devices. There is some relative contraindications like increased risk of aspirations, prolonged bag and mask ventilation, patient is morbidly obese, second and third trimester pregnancies, upper GI bleed, like this. Disadvantage of LMA over the ET tube. It has low seal pressure, high frequency of gastric insufflation, and complications. Danger mask family. It's a classic, just to brief, this is the classic element. We are very well aware of this. We are using in our OTs. Okay? This is a this is the cuff, this is the aperture bars, the tubes and connectors. Okay? I'm not going too deep in this. And beside this, I just show you the video how to use element. This is the method to first we have to deflate our laryngoscope, or it should be done on a flat surface, okay? So that it has not uneven surface during insertion. Okay? Then we have to apply jelly behind it, just a small amount of jelly. So just it's glide the LMA in the oral cavity like this. And we have to put our index finger just behind the bulb.
Holding is a parallel tension, then inserting with the help of index finger.
Just in volume, yeah.
लेक्चर में उतर गया था तो
Just
ज़्यादा नीचे चुटकी ले लेता हूँ कब से
when the we inflate
पिंकी तो इसको
the element, then we connect our back mask,
किसकी मारी बाबूजी
ambu bag, and if chest size is there, it makes, or it will be confirmed with the antidal CO2. So this is the briefing of how to insert element. Okay. Or we can hands-on in later on. Stand on, rest on upper esophageal sphincter. Sides of the cuff are in piriform fossa and upper part of the cuff behind the tongue base. Okay. There is some problem if we are not deflated properly before insertion. Like this, there is an uneven surface during insertion. It can be folding tip is there. It can obstruct the airway. Okay. So we should be very careful. As I discussed, first you have to deflate the LMA on a flat surface with the pressure of your two fingers, so that the insertion surface should be smooth enough. During insertion, there is no tip modulation there. And tip should not fold during insertion. Okay. This is the LMA unique. This is just a disposable version of classic LMA. This is flexible LMA. It has a reinforced tube. So it's mainly indicated in head and neck surgery. So there is a common area for surgical and anesthesia part. So we don't have access after the full draping the patient. There is a chance of kinking of tube is there. So that's why it's invented is reinforcing manner, so that its lumen should not be kinked. It's a soft seal element, just its bulb is making more soft, so that less chances of ischemia. This is the LMA fast track. This is developed to facilitate intubation through the LMA. Okay, I'll show you a video of this so that you can. Okay. It has three parts. like this. This is the LMA part. This is the insertion tube, and this is the ET tube, which can insert with this. Okay. So this is the first. This is the LMA part, which is introduced like other LMA also. Okay. But it has a channel holding is there, so that it can what is the maneuver to insert the ET tube through this animal? Maneuver is called as Chinese maneuver. Chinese maneuver is used to insert in ET tube through the LMA. So first we lubricate this, and through this we can put ET tube.
Now, our focus was mainly on classic LMA. However, when we talk about ILMA here, in management of difficult airway, it is quite relevant. It has been included in difficult airway algorithm. The technique is a bit different from the classic LMA insertion. In classic LMA, the airway tube is long and the airway tube is not rigid, right? And therefore, you have to give extension to the atlantoaxial joint and to the neck. And you have to open the mouth fully wide. And you have to press on the junction of the tube and the bowl from your index finger and apply pressure on a prepared lubricated back of the air of the bowl in such a way that it goes along at the tangential. The pressure is applied by your index finger tangentially all along when it is pushed towards the oropharynx till it finally engages and is further not possible to push it, right? So it typically takes the path of a food of bolus an infant will swallow, right? So this is how it is inserted, and then you inflate it and then you allow it to make a seal in periglottic area, and that is how it is done. Whereas when you use the intubating LMA, it has got a firm tube. So the fast track, what you call fast track, has got a steel tube, whereas other variants which are single use disposable, they have got a PVC tube which has got some firmness, not as much as the steel tube. But the design is the same, more or less at a right angle, right? And when this is inserted, you have to keep the patient in neutral position, right? So that is one point I am talking about, fast track in particular. So patient has to be in neutral position, and show the fast track का एक वो दिखा दीजिए, and you have to hold the handle. It has got a handle, steel handle, and you have to hold the handle in such a way that the mask is parallel to the chest of the patient. We can show you there. Those of you who have seen or have used it are familiar. Wasting much time in describing it, how to do it is not relevant. So you have to hold it like this, and in a single arc-like motion, you glide inside the open mouth, right? So she's approving the way I'm telling. So
My thesis was on island insert.
Now, once it is placed, you have to inflate the cup with the required quantity of air or recommended quantity of air. And in the second stage, so this is how you can use it as a supraglottic airway device. However, if you wish to intubate through it, there is a channel available. It is suitable for allowing insertion. of a tracheal tube up to size 8. There is a specific tube which has been designed to be used through it. It is similar to your other flexometallic tubes, however it is straight, a little longer. It has got a Murphy kind of latex tip which helps. It was initially designed for blind tracheal intubation. So it is a 2-hinge needle type of tip, right? And it has got a vertical marking on one side for alignment and position. And the most important thing is that it has got a horizontal black line. That black line coincides when the tracheal tube is being passing through it. The black line coincides with this steel tubing, the most proximal part of the steel tubing. So, when the tube is at this place, you will have that black mark here, and this is when the tip of the tube is pushing up the epiglottic elevating bar and is just emerging out of the bowl. And at this point, when the correct placement is there, then it is just in front of the glottis. And even when put blindly, more than 90%, and what I encountered was in 97% of the patients, it was suitable for blind tracheal intubation. Currently, we are having one dissertation going on this. Ritu is doing it. She has done some cases. Some she is, I think, she plans to. So this is what, and he was talking about. So he was talking about that maneuver. That maneuver is meant to increase the success rate of intubation when you are doing it the ILM, right? Chandy, once again, like Malampatti, Chandy is an Indian-born anesthesiologist who graduated from the PCI Chandigarh. Obese person and has been a frequent visitor in ISA conferences. I don't know how many of you have met him. So he has been working for quite a long time with Archie Brain and his group, and Chandy's maneuver is precisely to increase and improve the success rate of intubation. And the first step of Chandy's maneuver is that after you have placed the ILMA and inflated it, you need to optimize the ventilation. So optimization of ventilation is the way of increasing the success, right? It has been designed in such a way that when the ventilation is most optimum, the tracheal tube is going to be in front of the glottis, and it will be grade 1 and grade 2 kind of a tube, right? So for optimizing the ventilation, you have to lift it up, right? And thereafter, in the second stage, you have to move it up and down in midline and find the best position where the ventilation is good. You hold it at that place and then lift it up, and it is at this place that you intubate, right? So this is the Chandy's maneuver. However, it is a clinical way of improving the ventilation, and we are going in due course of time. We will be working out using fiber optic microscope as to which is the best position and which is the best maneuver to increase the success rate. So with that, you want to talk more about it? No, sir. So you know that the supraglottic airway devices, the classic LMA and now the intubating LMA is an important component of management of difficult airway, and it comes in the difficult airway as well. Now we are going to have a very quick and short break for breakfast, and we will come back in around 7 minutes.
We have known that the video laryngoscope has a significant improvement in endotracheal intubation, so it improves the airway safety. It is generally believed that video laryngoscope improves the visualization of laryngeal opening. It is the most important airway structure for intubation, so to increase the success rate of intubation. As the Dr. Kalpana told you, for the direct laryngoscopy, the alignment of 3 axes are required, oral, pharyngeal and laryngeal axis. It is done by the extension at the atlanto-occipital joint and flexion at the neck, in the cervical flexion. For video laryngoscopy, it is used optical technology, so there is no need of alignment of 3 axes for the laryngoscopy and visualization. In the history, evolution of video laryngoscope, first in 1940, Miller introduced, the Miller blade and Macintosh blade was introduced, and the video laryngoscope was introduced after the 2000. First the glidoscope was introduced, then AirTech, C-Track and TrueView are there, and the last CME was also introduced. It is also has been included in the difficult Airway algorithm. The classification of video laryngoscope is depend upon the blade type, as Macintosh blade or angulated blade or anatomically shaped blade with the guide channel. In the Macintosh blade, it is the stores VMAC, CMAC and McGrath. In the angulated blade, glidoscope, McGrath and store C blade. And in the anatomically shaped blade with the guide channel, there is the Pentax Airway scope, AirTrack and King Vision. It is the easy classification, video laryngoscope, non-channeled and channeled. In the non-channeled is the glidoscope, McGrath, store CMAC, UV scope and King Vision. King Vision has both blade channeled and non-channeled way. In the channel is the AirTech and the Pentax. The advantage of video laryngoscope, as you see, is no need of alignment of the 3 axes as in the case of direct laryngoscopy. Less force is required than the direct laryngoscopy. Less cervical spine movement. Because of the less force is required and less cervical spine movement, so there is a less hemodynamic stress response as compared to direct laryngoscopy in intubation. There is a short learning curve, useful teaching tools, and generally higher success rate, especially in the difficult situation. The disadvantage, passage of ETT may be difficult despite good view or higher Pogo score, and still it is required. I will further cover in my lecture how will you achieve full visualization and successful tracheal intubation in the case of video laryngoscopy. Fogging and secretion may also obscure the view. However, the new video laryngoscope, they have anti-fogging mechanism. There is a loss of depth perception. No single video scope is ideal. There is a greater processing time and different technique of laryngoscopy in intubation with different makers and different models. Uses of video laryngoscopy in the single lumen endotracheal tube. Also useful in the double lumen endotracheal intubation, in the nasotracheal intubation as I told you in the cervical spine pathology for McGrath, C-blade, D-blade and AirTrack are useful. It is also very useful in the COVID-19 era where the direct contact with the patient is avoided. It is also conducive for flexible fiber optic bronchoscope and insertion of different devices in the oropharynx. It is also useful as an educational and research tool of. Now the first video laryngoscope, glidoscope. The reusable glidoscope design utilizes a high resolution micro miniature video camera embedded in a plastic laryngoscope plate. The glidoscope direct, designed to assist in the teaching of direct laryngoscopy, is a Macintosh 3.5 plate with a traditional view axis of 90 degrees. And the glidoscope titanium, it is a full color imaging with the LED illumination as well as having anti-fog technology. Successful tracheal intubation, tracheal tube placement is best achieved by the help of a stellate in the shape of hockey stick with a bend at 90 degrees. CMAC video laryngoscope, it is developed and manufactured by the Karl stores. Macintosh blade is attached to a handle and a light bundle or image bundle is threaded into a small metal guide tube which is recessed 40 mm from the blade tip. It is installed in a small cart so that the device is easily moved, and the cart support a 8-inch monitor mounted on a swivel arm placed on the patient left side. The comparison of CMAC and VMAC. CMAC consists of an electronic module utilizing a semiconductor chip technology and consists only 3 parts: a laryngoscope, electronic module, and separate 7-inch 18 cm monitor The monitor connects to the electronic module that plug into a laryngoscope. And the VMAC, it consists of a laryngoscope, a bulk 8-inch monitor, a light source and a camera control unit. A fiber light cord and a camera cable emerge from the top of the handle. CMEC video laryngoscope. The CMEC device with a 2-inch pocket monitor also attached to the handle. The device incorporates lithium-ion battery technology with 2 hour battery capacity, and the pocket monitor displays a clear image under a strong light. These are 3 CMEC reusable metal Macintosh blades size 2 to 4 for the adult patient, and another CMEC latest CMEC handle is lightweight with a multifunction interface. McGrath video laryngoscope. It is a slim, disposable, transparent, regularly shaped blade similar to Macintosh blade and a wide LCD screen attached to the handle. Tracheal intubation is easier and faster for the novice also. Minute by minute battery indicator and auto off optimization of battery life is displayed in this. One handle has multiple blade option. It is also useful for pediatric and adult patients for routine and the extreme areas. McGrath video laryngoscope, when we compare McGrath with the CMEC, this is the CMEC, this is the McGrath. McGrath differs from the CMEC. It is lighter and had more compact screen and had a slimmer blade, and screen has a greater proximity to the axis of blade. So the McGrath has a slim blade and more advanced screen, compact screen. Now the King Vision. The King Vision device consists of a 2.4-inch reusable organic light emitting diode display and a disposable rigid blade that also include a CMOS complementary metal oxide semiconductor video camera. The King Vision is a wireless and a fully portable video laryngoscope which have a high blade angulation, making direct visualization of glottis unlikely. So we can visualize the glottic structure in the monitor only. The blade size 3 is provided for adult use, tube size 6 to 8 mm. This advantage in patient with cervical spine instability. 2 types of blades are available, one with the integrated tube guide, channel blade and non-channel blade and non-channel blade. Both models have high blade angulation, blade angle 90 degree with a similar shape. It is fully portable and wireless video laryngoscope and also having anti-fogging mechanism. AirTrack SP is a single-use device. AirTrack Advanced Disposable Blade plus Reusable Optical. AirTrack SP incorporates 2 channels. One transfers the image to the proximal viewfinder through a series of prism and lens, and the other acts as a conduit for the endotracheal tube. No stilate is required, avoid potential injury and eliminate the stilate cause. 90-degree shape, minimize hyperextension of the neck. It is useful for difficult tracheal intubation and the patient with cervical spine immobility. It also has anti-fogging mechanism, different size for pediatric and adult patient, nasal and double lumen tube version are available. Now the Pentex Airway scope, the disposable transparent blade, P-blade, with a 12 cm cable, with a charge coupled device, CCD camera, and 2.4-inch full liquid LCD monitor display, liquid crystal device monitor display. It is for quick and easy tracheal intubation. Insertion possible without the need to extend the neck. Also useful in the case of cervical spine instability. A crosshair display on the screen, making it easier for less experienced person to use the Pentex Airway scope. Utilizing high resolution color image, so the identification of anatomical structure is easily obtained. Split type Postman video laryngoscope. It is a newly recently introduced, having a channel blade. It is reusable core, disposable blade and monitor, 92-degree channel blade. Stilate is not required for the intubation. Core is completely enclosed by the blade, so there is no need of sterilization after each use, and the monitor can be rotated and tilted. So the limitation of video laryngoscope, as we told, fogging and secretion may obscure the view. This passage of view may be difficult despite great view. It is known as the laryngoscopic paradox. Depth perception is lost. Is the injuries of soft tissue such as soft palate, tonsillar, pharyngeal wall perforation are there, and the time demand for the operator to learn how to use them properly. Despite good glottic view, they is unable to pass the tube. So we have to learn the mnemonic CCLL. Choose the right tube. Check the endotracheal tube curve. Lubricate the stellate and the endotracheal tube, but not the camera and the light source. And load the stellate and bend it according to the angle of videolaryngoscope blade. This is a scenario. Despite good glottic view, unable to pass the tube. A common mistake being made in the videolaryngoscopy user, we have to cap the blade in the valvula. If you put your blade more near to the glottic structure, you are able to visualize the larynx completely, but you are not able to intubate the patient. It is a common mistake in the direct laryngoscopy also, but in the videolaryngoscopy you are seeing on the screen. So you should not place your blade of the videolaryngoscope too close to the glottis. And you can also put the endotracheal tube by this.
Don't make CL grade 1.
हाँ, भाई ऐसा नहीं है एपिग्लॉटिस पे ब्लेड को डाल के उसको लिफ्ट कर रहे हैं कि मैम हमें ग्रेडिंग इंप्रूव करनी है, बस आपको वेरिकुला में प्लेस करना है.
Will not follow it. Okay, because videolaryngoscope is very accurate, but your tube will not follow the course of videolaryngoscope if it is not channeled. So don't try to make CL grade 1 in the videolaryngoscope. Okay, keep your blade somewhat proximal from the valvula, and then in that picture, the previous picture, the second one. Okay.
आपको कितना अच्छा ग्लोइंग दिख रहा है ना, लेकिन you are not able to intubate the
able to
patient.
see the epiglottis covering the anterior commission, then it will be easier to put the tube with videolaryngoscope.
I would like to recommend use the bougie.
Yeah, bougie or stellate, always with the videolaryngoscope.
Because with the tube, because the tube is of larger bore, so it may not pass easily, and then by the time your laryngoscope will get fogged down. So use the bougie. Once you are in, then you can recruit the tube easily over.
And the videolaryngoscope आप बल्कि देते हो डायरेक्ट laryngoscope ना, तो आपको स्पेस भी कम मिलती है. तो you should use bougie or stellate for the tracheal tube intubation. And the one condition, ETT not passing toward the gloating opening, make C-shaped hockey stick, ETT with the stellate, lubricate and introduce. Second, stellate along with the ETT hitting against the anterior tracheal wall. Remove the stellate before advancing the endotracheal. ये डायरेक्ट laryngoscopy में भी होता है ना, stellate आपका टच करता रहता है, उसको remove करो, then निकालो. ETT hitting against anterior tracheal wall and not able to pass. Then rotate the endotracheal tube over the stellate and then intubate. Limitation of videolaryngoscopy. To avoid the limitation, we have to use this is a 4-step procedure. First step is to look in the mouth and insert the videolaryngoscope blade under direct vision. ठीक है ना? You have to look in the mouth and insert the blade under direct vision. Second step is look at the screen by gently advancing the blade toward the epiglottis to get the best glottic view. पहला माउथ में देख रहे हैं, laryngoscope को इंट्रोड्यूस कर रहे हैं, अब आप स्क्रीन पे देख रहे हैं. Third step is move to look again to the mouth while inserting the tube under the direct vision to avoid trauma of the soft tissue. Fourth step, again look at the screen to complete the intubation. आया समझ में? फर्स्ट स्टेप में क्या किया आपने? माउथ में देखा, laryngoscope को आपने इंट्रोड्यूस किया. अब सेकंड स्टेप में किया आपने स्क्रीन पे देखा, आपने जब आप ET2 को आप प्लेस कर रहे हो. थर्ड स्टेप में वापस माउथ में देखा कि कहीं आपको असर तो नहीं एंडोट्रेकियल ट्यूब प्लेसमेंट में आप सॉफ्ट टिश्यू इंजरी कर रहे हो. वापस आपने स्क्रीन पे देखा और ट्यूब प्लेस कर दी. The second one is lighted intubation aid. These are the light vent, track light. It consists of 3 parts: reusable handle with a 3 AAA battery, flexible reusable handle, flexible belt, durable flexible plastic shaft with a bright light bulb affixed at the distal end, and there is a metal wire stellate. And other flexium tube state and fiber optic lighted intubation stellate. शायद ये हमारे पास है ना fiber optic lighted intubation stellate. The working principle of lighted intubation aid. They are used the principle of trans-illumination of the soft tissue of the anterior neck to guide the tip of the ETT into the trachea. This method takes advantage of anterior superficial location of the trachea related to the esophagus. When the tip of the ETT with the latent stellate enter the glotting opening, a well-defined circumscribed glow can be readily seen slightly below the thyroid prominence, from which you can also see. तो अगर दूसरा पर्सन है वो देख सकता है कि आप राइट प्लेस पे हैं नहीं, अगर लेफ्ट में है राइट में, यू कैन गाइड who is intubating the patient की लेफ्ट में है या राइट में है, सेंटर में नहीं है, क्योंकि आपको एक अच्छा खासा ये ब्राइट रेड क्यों दिखाई देता है. The technique of use: the distal end of the stellate should be lubricated with the water-based surgical lubricant and we load the tracheal tube. Oral intubation in the non-dominant hand is used to for oral intubation, the non-dominant hand is used to open the mouth, and the hand should be kept as lateral as possible for the midline placement of lighted intubation stellate. Intubation stellate should be placed from the midline, not from the right corner of the mouth. So you have to open the mouth with the non-dominant hand. It should be placed as lateral as possible. Then introduce your lighted intubation head from the middle of the mouth. The lighted stellate is introduced into the oropharynx from the side and brought into the middle. The tip of the light bag should be passed under the tongue with a gentle anterior traction. A bright, well-circumscribed circle of light at the level of hyoid indicates that the tip lies in the vallecula, and the gentle forward pressure may displace the epiglottis, allowing immediate tracheal intubation. The complication: dislodgement of bulb attached to the distal end by removing the lighted stellate. The bulb might get heated and may be a source of thermal injury, and the possibility of heat damage to the tracheal mucosa. Is a trauma of the upper airway there, and the most severe upper airway damage reported after latent stellate are the intubation or the arytenoid cartilage desiccation. Contraindication: upper airway foreign body, tumor, polyp, any pharyngeal abscess, or any tribal tissue around the intubation force. Thank you. Do you have any questions?
I'd like to thank Ravindra sir and Avnish sir for giving me the opportunity to present this fiber optic bronchoscopy guided intubation. This is more of a practical aspect. So I have divided my presentation into some slides and a video. So as the fiber optic is black or white, so are my slides black or white. So why do we need alternative techniques of tracheal intubation? Conventional rigid direct laryngoscopy aids tracheal intubation in 98% of the cases. However, even the most experienced operator may encounter difficulties with the rigid laryngoscope, and hence alternative techniques and equipment for endotracheal intubation must be readily available for the remaining percentage of the cases. Dr. Peter Murphy was the first to use a flexible fiberscope to perform tracheal intubation. He performed the intubation as a registrar at the National Hospital, Queen Square in 1967. So, as we all know, this is the these are the components of fiber optic. This is the eyepiece, which the camera is attached here. This is the tip of the scope, and then this is the main part, that is the insertion cord, flexible fiber optic shaft, it is also known as. This is the lever which allows the movement of the tip up and down, and this is the source to attach the light. The insertion cord is a main component which contains collection of approximately 10,000 glass fibers, 25 microns each in diameter, which is approximately the diameter of our hair. To keep the light from being lost during transmission, each fiber is coated with a 1 micron layer of glass having a different optical density, which helps in the total internal reflection of the light entering the fiber. The individual fibers cannot provide a good resolution, and hence there is a need of collection of approximately such large number of fibers in a bundle. So quickly I'll describe the indications. First is the previous difficult intubation. If suppose a patient has had a previous difficult intubation, congenital abnormalities, anticipated difficult intubation in congenital abnormalities, or acquired abnormalities like there is a cervical spine spondylosis, TM joint ankylosis, trauma like fracture, laceration, cervical spine instability, upper airway laceration where you want to plan electively a fiber optic intubation because you have already suspected that there is going to be a difficult airway. Anticipated problems again like obesity where there is a short neck, micromathia, protruding teeth. Situations where it is beneficial to access a patient's neurological status after intubation, where you want to plan an awake intubation, but prior to surgery, for example, those with an unstable cervical spine injury, and patients at risk of aspiration of gastric contents who require intubation but are known or potentially difficult to intubate. But there are several contraindications like the absolute one is the patient's refusal, edema of the pharynx or tongue, tracking, infection with inflammation and hematoma. In all these situations, the field of fibroscope is greatly reduced. The blood and the secretions in the oral cavity is a relative contraindication though, because a senior anesthesiologist who is practiced and who is well versed should try only once because there will be obscuration of the vision. Presence of pharyngeal abscess which can be disrupted as the ETT is railroaded over the fibroscope, lack of time, inexperience and local anesthetic sensitivity, and also non-compliance like children and special needed patients. Also, if there is a profuse bleeding in the airway. Critical airway. Now what is critical airway, which is a relative contraindication? A patient with stridor has an airway that may become obstructed completely with minimal provocation. For example, when we do oncosurgeries, we always see what is the chunk of the airway. If there is no chunk or there is a minimal access of the airway, that is a known anticipated high severe airway obstruction which can become completely obstructed. In such situations, inserting the fiber optic through the narrowest part may cause complete obstruction and you might land up into problem even before intubation. And hence, in such situations, alternative techniques like awake tracheostomy should be considered to secure the airway. Now, there are two approaches, oral or nasal. Many anesthetists prefer the nasal approach initially as this tends to offer an easier line of access to the larynx and is usually better tolerated by the patients. Nasal pathology and a current or previous history of epistaxis are contraindications to this route. The mouth has a greater volume than the nose, but it can be easier to stray from the midline position when inserting the scope. In this situation, I'm talking of the oral approach. In this situation, a split oral airway like Berman or Ovasithin can help. So this is the Berman airway. These airways are similar to the conventional airways that we have, the oropharyngeal airways. The difference is that they allow the passage of both the fiber optic scope as well as the tube that is to be railroaded. Their design allows them to be removed from the mouth without dislodging the scope or the tube after intubation. So briefly, the 10 essential steps to perform an awake fiber optic intubation: ensure the proper appropriate indication, explain the procedure, take the consent, give pre-medication, prepare the equipment, railroad the tube over the fibroscope. Recently, we were doing fiber optic. The first resident started doing the fiber optic, and we reached the vocal cord, and there is no tube inside. So that must not happen, especially when it is anticipated difficult airway. Monitoring oxygen, IV access, commence sedation if the patient allows for sedation. If there is no complete obstruction possible, if you're not anticipating complete obstruction, in such situations, sedation must be avoided. I will describe that later. Position the patient and ensure appropriate level of sedation. Anesthetize the airway. Perform intubation, confirm and administer the general anesthesia. So this is the fibroscope that we will be showing in the workshop. This is the north-facing cortex endotracheal tube that is being already railroaded. So before doing anything, we need to ensure that there is a functioning light source that is compatible with the fiber optic. We focus it by visualizing the fine point. The camera is attached, the camera lens is refocused, and we make sure that the camera is oriented correctly by ensuring the black triangle or other marker in the visual field of scope at the 12 o'clock position. The tube is railroaded and secured either by a small piece of tape or a microprobe. Then the person who is doing it must wear sterile gloves. The fibroscope should always be held at the most distal point as close as possible, like when you hold it and you start inserting it. So it should be held at the most distal point, which is as close as possible to the patient's nose or mouth as possible, and should be kept straight to avoid kinking and fracture of the fiber optic strands contained within it. Hold the scope in your dominant hand with the lever on the control body pointing towards you. Many a times I have seen the residents pointing in the opposite direction. The lever must be in front of you so that you negotiate accordingly. That is a wrong practice to keep in the opposite side. In this configuration, moving the lever up with your thumb will move the tip of the scope down, and moving the lever down with your thumb will move it up. So there are 3 possible movements in total which are possible with fibroscope. Tip up and down, as I told, the scope inserted deeper, inserted or withdrawn, and clockwise or anti-clockwise direction on the scope.
We are a practice to hold the flexible fiber optic bronchoscope in the non-dominant hand, in control with the non-dominant hand thumb, and we are introducing the tube or the flexible fiber optic bronchoscope with our dominant hand.
So as what ma'am has said, if suppose we assume that this patient has a left non-dominant hand, so the left hand is holding above and the right hand is holding at the tip. So looking at the left, so we are elevating the tip, lever down and up, and rotating the scope anti-clockwise or clockwise, and rotating it 90-degree clockwise. So endotracheal tubes that are being railroaded over the fibroscopes, what is their importance? The choice of endotracheal tube depends on the clinical situation as well as the tube availability. Reinforced endotracheal tubes are commonly used, which can be placed orally or nasally. The endotracheal tube that comes with ILMA, as we described, has a curved 2E style tip, allowing the leading edge of the tube to run close along the scope when it is pushed over it. So I'll show this. On the left side is the armor tube on the left with the prominent lip. This is the prominent lip as indicated, and this is the ILMA tube that I was describing, that there is has a curved tip. So that will reduce the likelihood that the tube will get caught at the arytenoids while we are placing it through the ILMA. Okay? So this is the type of tube, and Portex north-facing tubes, typically size 6 for females and 6.5 for males, are often used for maxillofacial procedures. They are of soft material and connection is positioned away from the surgical field to allow the surgical access. So this was about the tubes. Now we come back to the patient. So after giving an anti-cellulose, what are the steps, what we have to decide? After giving the anti-cellulose, we need to understand that operator can stand back either in front of the patient or at the back, that we usually perform in the OTs. Both have their advantages and disadvantages. Sedation, as I said, if allowable, has to be given conscious sedation. So some centers where I have worked in Bombay, they never give any sort of sedation at all. Like 15 minutes of lignocaine nebulization is given prior to maybe half an hour prior to the surgery. They have this rule that they'll give 15 to 20 minutes of nebulization, that is must, and anti-cellulose blocks and no sedation. Because there are times when you are dealing with severe obstruction, as I said, with critical airway, and you give some sedation, you will land up into problem even before putting the tube. And sometimes in minor OTs, help is not available. So in such situations, if sedation is allowed according to the scan of the airway or some X-ray that you have available, you must look that and then decide what you have to give. So we can give, like in our hospital, we do give fentanyl, some amount of fentanyl we can give. Some centers are giving Dexmed also, but it must be decided with the CT scan of the airway if you are dealing with. Then oxygen delivery should be given with nasal prongs. Then we deal with local anesthesia of the airway. So anesthetizing the airway, we need to anesthetize the nasal passage, oral passage and the larynx. I'll describe that in detail. So medial and lateral, anterior ethmoidal branch of the nasociliary nerve is supplying it. Then the floor is supplied with the superior dental nerve, and posteriorly the long and short sphenopalatine nerves from sphenopalatine ganglion. So we give oxymetazoline and xylometazoline 0.05%, which is instilled in the nostrils, and spray 3 to 4 ml of spray of 10% lignocaine. In the pharynx, the nerve supply is glossopharyngeal and vagus nerve. 10% lignocaine spray sprayed at the tongue, soft palate, uvula, oropharyngeal wall, and nebulization. As I told, flow oxygen through the nebulizer and channel nebulized lignocaine, which is highly effective. Larynx, in short, sensory above the vocal cords by SLN, that is the superior laryngeal nerve. Below the vocal cords is supplied by the RLN, and trachea by the vagus. So this is the SLN block, which I'll describe, that we need to press at the contralateral greater conua of the hyoid bone, laryngeal structures displaced, and a needle is walked off the conua of the hyoid bone, as we can see in this slide. The needle is walking. So aiming in the direction that is of the thyroid ligament until it passes through the ligament at the depth of 1 to 2 centimeters, 2% of lignocaine injected between the thyrohyoid membrane and the pharyngeal mucosa, and then you repeat it on both the sides. So it is given bilaterally to block the superior laryngeal nerve. As we can see in this is the greater corner. So this is the thyrohyoid membrane. This is the thyroid, and you compress it. So pressing the contralateral greater conua of hyoid bone, laryngeal structures are displaced towards the side to be blocked. So this is SLN block. Then another is the transtracheal block that we all give in the between the thyroid, and as Namita ma'am had told about the anatomy, between the thyroid and the cricoid cartilages. And after you give, you have a loss of airway resistance. Air bubbles and you aspirate, and you give 3 ml of 4% lignocaine. So these are the the airway anesthetizing steps. The NEGM journal describes nasopharynx anesthetization with cofenylcaine, which is sniffed between the nostrils. Oropharynx, they use some mucosal atomizing devices with this needle, that is with 10% of lignocaine. And larynx, as I already said, spray as you go technique. That is when we are negotiating the scope inside, at the level of vocal cords we spray, and again inside we spray, so that there is minimal interruption from the patient's side. So this is the figure which is showing 2 ways of intubation, with the operator either standing behind the patient, this is behind, and in front of the patient, this is in front of the patient seeing the monitor. So what are the benefits of operator behind and operator in front? So I'll describe operator behind in the first picture. The familiarity with the position is more. There is a good line of access, and better for patients who are unable to sit up, like cervical spine injury. In front, like this picture, the patient is little, as you can see, head up position or in a sitting position. So in this, the eye contact between the patient and operator is better. There is less pooling of secretions, more comfortable for the operator as it's less tiring. Also for the patient, airway is more open and better patient ventilated in this condition. So now the steps of fiber optic. Nasal fiber optic pass a soft nail. First we put a nasal airway to ascertain the good patency. Replace this airway with the EG tube with the same length. So फाइबर ऑप्टिक करेंगे तो हम पहले लोड करेंगे फाइबर ऑप्टिक. I'll show in the video, and up to the level of control section, remove the nasal airway and introduce the fibroscope. The head of the fibroscope is kept in the right hand, thumb over the control lever. Scope is passed behind the soft palate and tongue. Epiglottis is identified. Advance the scope under the epiglottis to view the vocal cords. Additional sprayed lignocaine through the working channel of bronchoscope. Further advance until carina is seen, and then we pass the railroaded endotracheal tube. So now, as we can see, this is the nasal approach. So this is the nasal, the starting of the nasal airway. So can anybody tell me what are these A, B, and C? Ritu? What is B? So these are the when you do fiber optic intubation. What are the steps? What are the things that come across? So Rajkumar, what is B and C? So B is the inferior turbinate, C is the choana that we are seeing, D is the posterior pharyngeal wall. So E, what is E? With anybody, Nupur? Posterior pharyngeal wall. And then now you see the complete picture of the glottis in the F. This is the picture that you must see. What is F? What will you call as F? you are seeing the complete two arytenoids in the F, and then you advance the scope, right? Then you advance the scope in between the vocal cords, and this I is showing the tracheal rings, and then this is the carina. So this picture must be kept, first years, this picture must be kept in mind that unless you see the carina, you cannot come back. So you have to see the carina, then advance the tube, come back, and while you come back from the fibroscope, these images must be again seen retrospectively, right? So what are the problems that can be encountered when you are doing a fiber optic? One is the blurred view. It can be because of blood secretions. You must, ideally when there is blood or airway, as I said, if an avoidable situation must be avoided, but if the fiber optic has to be done, must be done by the trained anesthetist. So in that situation, use an anti-cellulose, use suction catheters, inflate oxygen down the suction catheter to disperse the secretions, introduce the fibroscope carefully under direct vision from the beginning, and use direct laryngoscopy in combination with fibroscope as a 2% technique. What if you can't find the larynx? If the condition can be either the larynx is displaced, so a jaw thrust can be given, tongue protrusion can be done, and direct laryngoscopy can be used as well. If there is a floppy epiglottis seen inside the fiber optic, then we can use a head-up position or either place the position in a lateral position. What if the other condition is, what if the fiber optic passes in the vocal cords but not the tube? The tube is not, you are not able to negotiate the tube inside, but you are able to negotiate the fiber optic. Rotate karke dalenge, right? So the tube sticks at the arytenoid cartilage. They are hindering the passage of the tube. In that condition, rotate the tube 90 degree anti-clockwise and then redirect the tube so that it is no further sticking through the arytenoid cartilages. Then again, if you can't find the larynx, the landmarks can be destroyed either by the tumor or edema. Ask the patient to vocalize or pant to identify. Look for bubbles indicating sometimes there is no view. So if suppose there are gas bubbles which indicate the gas flow, inspect any hole with visible tracheal rings. So as I had described this image, can anyone again tell me what are the images? Second year? Tanuj? What is A, B, C, D, E, F, G, H, I? Right. What is B? Inferior turbinate. C? Quana. D? E is posterior pharyngeal wall. This is the soft palate. F? Arytenoids. Then this is the epiglottis advancing in the vocal cords, tracheal rings, and this is the carina. So unless we see the carina, we are not getting our fibroscope pulling out, right? So this is again in short this is the bronchial tree. I have shown the images from the beginning. Now I am describing in short the bronchoscopic view. So as we can see, this is the B point. What is this? This is the bronchoscopic view from the trachea. As you can see the carina. That was the last image in that. The edge of the carina is sharp. The posterior muscle stripe continues from the trachea to the main bronchi. Now after B we have C. This is the point C. So at C, what are you going to see? Shirin? It's right or left first of all? It is left. So at C you are going to see both left upper lobe and left lower lobe. So view from the left main bronchi showing left upper lobe and left lower lobe bronchi. Further branches of both can be identified in the background. Okay? And now after B, C, D aa gaya. So this is the right side, right? So at D, what are you going to see? The right main bronchus, because upar hai wo. So view from the right main bronchus is point D. The orifice of the right upper lobe is coming off at 90 degree to the right main bronchus. So at this D point, we are going to see both right upper lobe and the main intermedius, bronchus intermedius, right? At E point क्या है? E point पे क्या दिखेगा? Maninder, what is E point? It is the right bronchus first of all. It is the right side. So D पे अपन ने सब देखा है. E पे क्या दिखेगा? View from after passing the right upper lobe, or if it's showing the right middle lobe. Upper lobe चला गया है. The right lower lobe and the right apical lobe. So if at D point you are going to see all this, right? And F point at the left side is from the view from the left upper lobe. This is the left upper lobe, right? So at F point you are going to see view from the left upper lobe with the divisions to the left upper lobe superior to the division of lingular lobe, right? These are the in short views from the nostril to the bronchus, right? So again the tracheal cartilages, as you see, when we are putting fibroscope for the novice, when we are putting in the trachea, we have to see the tracheal cartilages, that is not esophagus. Tracheal cartilages are present in the trachea. So right bronchial tree, this is the upper lobe. I will be showing in the workshop also. Upper lobe, and this is the bronchus intermedius, right? And in the left bronchus, the upper lobe and the lower lobe. Again, the lower lobe is divided into the parts, and left lower lobe bronchus again into 3. So summary checklist for equipments: fully operational scope and TV monitor, monitoring equipments, suction, oxygen supply, whatever way you want to, different sizes of tubes, oral airway, if we are doing oral fiber optic intubation, must be there, and IV cannula, anti-cellular, cofenylkane, as this has been described by the NEGM, to the nostril, laryngotracheal mucosal atomization device, as I told, and epidural catheters are also used. 2% lignocaine to mouth to gargle, 1% over the atomizer, over back of the tongue, 4% log spray, warm sterile saline, and saline for lubricating. So what are the complications for awake fiber optic intubation? Equipment failure, bleeding, hematoma, complete airway obstruction, as I told, can happen in a critical airway situation, local anesthetic toxicity, poor view or fogging, excess coughing, esophageal intubation, failure to pass the ETT, the conditions that I described. That's all from my side. Thank you for patient listening, but I do have a video which is though colorful.
Sisodiya in clinical medicine from the New England Journal of Medicine.
Fiber optic intubation plays an important part in the management of a difficult airway and is recommended by many societies of anesthesia. It is primarily important for management to anticipate difficult airway, but can also be used to secure the airway in an unexpected situation. There are different techniques for both situations, the nasal and oral approach in the awake and anesthetized status respectively. The choice of the equipment and medication is primarily dependent on personal preference. This video will demonstrate a nasal approach in an awake patient with a difficult airway and will also demonstrate an oral technique in an anesthetized patient whose airway presents an unanticipated difficulty. Nasal fiber optic intubation is indicated when endotracheal intubation is required, but the patient has a known or anticipated condition that will render intubation difficult. For example, a patient with suprapubic tumor or an abscess in the neck region. Nasal fiber optic intubation is also indicated in patients with a limited mouth opening, for example, those with rheumatoid arthritis, cervical spine problems, or organ tissue. Fiber optic intubation may be considered when mask ventilation is likely to be difficult, as in patients with a body mass index of 30 or higher, a beard, abnormal neck anatomy, or an airway that allows only limited visualization of the laryngeal structures. Patients with 2 or more risk factors are particularly good candidates for a fiber optic approach. Lack of patient cooperation precludes using an awake technique, even in situations in which airway management is expected to be difficult. In such patients, general anesthesia should be induced only by experienced anesthesiologists. Oral fiber optic intubation is indicated in the management of an unanticipated difficult laryngoscopy in the already anesthetized patient, provided that mask ventilation and
so this is the airway that I described.
Possible until fiber optic intubation may be performed. Nasal fiber optic intubation should be avoided in patients with severe maxillofacial trauma, since the fibroscope or the tube may inadvertently enter the brain. Massive airway bleeding is a relative contraindication to fiber optic intubation and should only be used by experienced anesthesiologists. Gather the necessary equipment. You will need non-sterile gloves, a topical anesthetic with atomizer, 0.5 milliliters of 10% cocaine nasal drops, which is used for vasoconstriction and local anesthesia of the lower nasal cavity, a 2 milliliter syringe with a local anesthetic such as 2% lidocaine for local anesthesia of the larynx and the proximal trachea, a water-soluble lubricant, a flexible armored silicone endotracheal tube with an internal diameter of 6 milliliters, a 10 milliliter syringe, an anti-fogging agent, tape and a ribbon to fix the tube in place, and a slit oral airway for the oral approach. The diameter of the flexible fibroscope should be between 3.7 and 4.1 millimeters. Discuss the awake technique with the patient and obtain informed consent before surgery, preferably on the day before the procedure. Give the patient an oral medication with mild sedative effects, for example 0.15 milligrams of clonidine by mouth 60 to 90 minutes before surgery. Explain each step to the patient. While monitoring the patient, provide 100% oxygen by face mask, administer 2 micrograms per kilogram of fentanyl intravenously, and anesthetize the posterior pharyngeal wall with topical anesthetic spray. Prepare the inferior nasal cavity by applying 0.25 milliliters of cocaine inside each nostril and close the patient's nose by pressing on both sides with your thumb or forefinger, or ask the patient to do this. While you are preparing the equipment, be sure to oxygenate the patient adequately with a firmly applied mask. Thread the tube over the lubricated fibroscope and fix it with tape or with the appropriate adapter to the fibroscope. Check to ensure that the fibroscope is flexible and provides a focused view, and then apply an anti-fog treatment of the scope. Connect oxygen to the fibroscope and provides 2 to 4 liters of oxygen per minute continuously. Stand above the patient's head and explain each step as you proceed. Hold the fibroscope near its tip in order to get the best feel for the instrument as it proceeds through the lower nasal passage. Direct the fibroscope parallel to the patient's nasal floor.
So this is
By
the nasal
concentrating
passage.
the floor of the nasal cavity in view, you will prevent upward movements of the fibroscope, which directs it towards a blind recess. When you reach the posterior nasal pharynx, ask the conscious patient to stick out her tongue. This maneuver makes it easier to advance the instrument towards the epiglottis. Simultaneously, lift the tip of the fibroscope, making a slight downward movement with the thumb of the hand that is holding the instrument. If a patient is heavily sedated, a tongue traction maneuver is helpful. At the supraglottic region, introduce 1 to 2 milliliters of local anesthetic through the working channel of the fibroscope while administering oxygen to propel the anesthetic into the area. Advance the fibroscope posterior to the epiglottis and through the vocal cords, taking care to avoid any direct contact with the pharyngeal and laryngeal structures. You can facilitate the advancement through the glottis by making a slight downward movement with the tip of the fibroscope. Understanding the difference between the trachea, as only this area is sensitized. The introduction of local anesthetic within the trachea and the supralaryngeal region will improve patient comfort and render the procedure easier. Alternatively, you can introduce the anesthesia by direct injection by a puncture of the cricothyroid membrane. This direct injection technique is reliable, time efficient, and easy to perform. To induce general anesthesia, we prefer etomidate 0.2 to 0.3 milligrams per kilogram of body weight in non-critical care settings. Note that etomidate is not the drug of choice in critically ill patients because it may induce adrenal insufficiency. Thus, another intravenous agent such as midazolam or propofol should be used in critically ill patients. The administration of a hypnotic before advancing the tube in patients without a severely compromised airway increases patient comfort and may also decrease the reluctance of an anesthesiologist to perform fiber optic intubation in an awake patient. After the patient loses consciousness, advance the instrument towards the carina. If the patient has a severely compromised airway,
as I said, the critical airway,
even for the insertion of the fibroscope. Place lubricant at the nasal orifice and on the cup of the tube. Advance the tube using rotating movements. You may sense a slight resistance at the beginning of the nasal passage. Watch for the appearance of the tube on the screen of the fiber optic unit and place the tip of the tube 3 to 4 centimeters above the carina. Remove the fibroscope and attach the tube to the ventilation system of your anesthesia machine. If you find it difficult to visualize the larynx of a patient who is already anesthetized and have attempted conventional intubation without success, use bag and mask ventilation to maintain oxygenation. Then place a slit airway in a midline position. Ask an assistant to perform the chin lift and jaw thrust maneuver. Insert the fibroscope as the midline and follow the posterior wall of the oral airway. The end of the epiglottis can be easily recognized as you proceed. Advance the fibroscope through the glottis just above the carina as demonstrated previously. When the insertion of the fibroscope has been completed, remove the slit oral airway and advance the flexible tube using rotating movements while maintaining the chin lift and jaw thrust maneuver. After placing the tube with the nasal approach or the oral approach, confirm that the tube is in the correct position by feeling it through a line to confirm the correct from a standardized procedure.
That's all from my side. That's all I have described. Thank you.
So this was a very nice presentation, and many of you have witnessed the procedure, many of you have done it, and she has once again thrown light into what all goes into it, the tips and tricks, and the pictures you saw when you negotiate the airway, different places, how do you should be able to identify when you visualize them. And when you go for the workshop, you will see it for yourself. Now, what I want to tell you is that LMA insertion may not be that easy in the mannequin as it is done on a patient. On the contrary, the fiber optic intubation may be much easier in the mannequin. So that is the situation. Now I invite Dr. Ravindra for a very important deliberation of today's workshop. In fact, when everything fails, including fiber optic bronchoscope, how do you oxygenate the patient? That's most important. And for that you need to access the neck from the front and seek a definitive airway. You can do it with several techniques. He is going to tell you all in detail here, and we have got mannequins where you can practice it. I will also advise you to be careful when you are working in your intensive care unit or elsewhere where such kind of situations and percutaneous tracheostomies are routinely done, and when you are in your ENT posting, not to fiddle it out in cases which are not being done in general anesthesia, and when the tracheostomy, surgical tracheostomy is being done, you should be there joining the team or asking them to help you out there and at least giving you a commentary as to what is happening and how it is being done. So mostly you will not be required to do it, but we will give you a good insight into it. Okay? Please go ahead.
Hello, good afternoon all. Firstly, I would like to thank Sir to organize such a wonderful workshop. There are very few persons who take so much of headache for their PG students. So thank you, sir. So since morning you have been gone through all the anatomy, physiology, and to assess the difficult airway and rest other means of securing the airway by non-invasive means. But what, as sir told you, but what when everything fails? Then you are standing on the last step of the ladder. So you should master this thing also, because these situations are very rare. Very rare means I think once or twice in a year you will see such type of situations. So when the real situation, when you will encounter the real situations, that time you might not get click the things, what to do next. So it is very important to keep the guidelines in mind and to practice these all things over the mannequin and hands-on. You can have such situations more frequently if you mismanage the thing. So when is the need of front of access means surgically securing the airway? As the previous speakers told them, when there is a situation of cannot intubate, cannot ventilate and oxygenate the patient, then you have to have a front of a neck access. So what are these situations? When the tracheal intubation is failed. So this is according to 2015 when 3 attempts failed, but these all are the guidelines. Guidelines are to guide the things, not to stick the number that 3 or 3 plus 1 or what. It is not like that you are taking 3 attempts. Oh, I have to take 3 attempts plus 1. I will call the my senior one. Yeah.
But you are able to oxygenate or ventilate the patient at that time,
If you are able to. So this is very important when call for help and to assess the situation. Assessment of the situation is very important, whether this is difficult intubation or not. So whenever you are in doubt, as sir told, that this is not your ego that, oh, I am third year and I cannot intubate the patient, or I am senior resident, whoever, or I am assistant professor, so how can I call when this OT is assigned to me? So a call for help should be earliest, because patient is most important, life is most important thing. So if your patient is okay, you would be okay in the long term. So when the tracheal intubation failure at the mask ventilation, when mask ventilation is not possible, and when this supraglottic airway device placement, or even after placement, if you are not able to ventilate, means placement is not correctly, or this is a rough guideline that oxygen saturation, if you are not able to maintain the oxygen saturation about 90, 88 for a few minutes, then it should be alarming situation, and you should call for help, and you should start thinking of the front of neck axis. So you should start giving order that everything should be in place. So what should be the characteristic of the technique which we will going to use in the front of neck axis? These techniques should be different according to the situations. So it should be very straightforward, it should be simple, it should be easy to master, very limited steps so that you can quickly access the airway, and minimal complication. It should protect from the aspiration, and most important, oxygenation and ventilation should be proper regardless of the upper airway obstruction, because by this technique you access the airway infraglottic airway access is secured by the surgical techniques. So type of approaches. So type of approaches, the situation will dictate the type of approach. In what situation you are, who you are, means how much trained you are for the particular situation, or how for the particular procedure, how much trained you are, what is the condition of patient, is it very urgent, or as Dr. Namita told that it is semi-urgent or it is very urgent, what is the level of oxygenation you are partially ventilating, you are able to partially ventilate the patient or you are not, at what place in hospital you are in ER, you are in operation theatre, you are in ward, where you are, what is the age of patient, what is the anatomy of the patient, is it difficult patient, is obese, there is burn contracture at all. So you should look for the whole scenario, and this will dictate that what procedure would be the best in that situation. So we will go one by one. The needle cricothyroidectomy. So there are two way or two axes which from where we can get control of the airway. One is the cricothyroid, or below the cricothyroid is trachea. So from cricothyroidectomy you can use the needle, or percutaneous cricothyroidectomy, or surgical cricothyroidectomy, and for tracheostomy, as you all know, it may be the surgical tracheostomy or percutaneous tracheostomy. And what is the most important first step for every procedure? That is the correct positioning of the patient. And what is the correct position? Patient should be in the supine position, neck should be extended or hyperextended, so you can assess the anatomy of the patient well, and you may remain well oriented in the midline, and all the landmarks are very clear. So how you will achieve this position? By placing the pillow under the shoulder and head over the ring. If it is more urgent, then what else you can do? You can drop down the head end of the table if patient is on operating table. So by this way you can achieve the extension of the neck. And if patient is on trolley and the situation is very urgent, then what you can do? You can pull the patient on the head side when the head is hanging out of the edge of the trolley, and then the one assistant would remain on the head side by securing the head, and he will give the position of the patient for you. So as you see, this is the correct positioning of the patient where you can assess all the landmarks. So preparation before cricothyroidectomy, as I told, first is the recognition and declaration of the difficult airway. This is very important thing, and this comes after a lot of experience. That yes, this is difficult airway, this is not difficult airway. Call for assistance and help, call early. I would suggest call early, don't wait. Continue oxygenation by any means, by tight fitting mask, by cannula, by supraglottic device. By oxygenation, okay, this is not my topic, but as this is not covered in the previous lecture, so I would like to ask, when you are not able to ventilate the patient and when the patient is not breathing, then why you want to oxygenate the patient? How the patient will get oxygenated? Can anybody answer? यही लिखा है fitted mask, nasal cannula, by catheter, by any mean. So not jet ventilation, but how you will oxygenate the patient. This is called passive oxygenation. This is called passive oxygenation. So whenever you are trying by non-invasive mean, by invasive mean, there the patient should be get oxygenated by nasal cannula, by catheter, by high flow nasal cannula, or by any mean. The oral cavity, nasal cavity, there should be the oxygen should be going for passive oxygenation. So how the what is the procedure, or how the passive oxygenation will get happen when patient is not breathing? Pooja, we discussed yesterday how much oxygen is required per minute,
200 ml per minute.
and how much carbon dioxide is produced? 250 ml. So when 250 ml carbon dioxide is coming out and 200 ml oxygen is required, so there will be a certain amount of negative pressure inside the lung, and it will suck the few amount of oxygen inside. So if you will keep on oxygenating the patient longer time, that's why the pre-oxygenation is very important. If you pre-oxygenated patient well, then patient can stay, save it for 8 minutes, for 10 minutes, and if you are giving oxygen with the high flow nasal cannula, even up to 20 minutes, up to 30 minutes, the oxygen, the level of oxygen will not get fall.
So pre-oxygenation is for those who are ventilating themselves, who are breathing themselves.
Yeah.
Whereas if someone is paralyzed or not breathing, the apneic insufflation is useful.
So this is
here it is a function of flow and pressure breathing. And of course you have to make sure that there is no airway obstruction.
So it will give you a lot of time, though patient is not getting ventilated and CO2 production is continued. So the level of CO2 in the body will get rise. PaCO2 will get rise, but at least patient will be oxygenated. So this is the role of passive or apneic oxygenation. So then ensure the neuromuscular blockage when, because it will ease in your procedure, and optimal neck position. So these are the preparations whenever you are going surgical. So this has been covered, identification of cricothyroid membrane, laryngeal handshake. So how you will done, I think now everyone can, how you will done, how it will be done? By non-dominant hand. When if you are right-handed, then you are standing on the left side of the patient, and on with your left hand, middle finger and thumb, you will stabilize the larynx or thyroid, and from the index finger go down, from the Adam's apple go down, and the first dip is the cricothyroid membrane.
So when you are doing this procedure, don't want to harm the patient, you use your non-dominant hand.
And when you want to harm somebody, then you all right?
So this is the cricothyroid membrane. It is between the thyroid cartilage and the cricoid cartilage. So first technique is the cannula technique, narrow bore cannula technique. When the indigenous cannula or the IV cannula of 14 gauge, 16 gauge, whichever is available to you, then you can, in emergency situation, you can have access and you can oxygenate the patient with this technique. So, which are the steps? Same, one, positioning, then identify the cricoid cartilage and puncture the cricothyroid membrane at right angle with the needle, and once you have punctured the membrane and negative aspiration of the air is confirmed, then decrease the angle to the 30 degree or 45 degree and hold the needle with the dominant hand or non-dominant hand, slide the cannula.
Now, identifying the cricothyroid membrane is most vital here, right? And one more thing that for doing this kind of a procedure, your epidural 2V needle may be quite useful, right? Because you can, it is less likely to cause trauma, and you can direct it thoroughly, and you can allow the flow also to be directed in the middle of the airway below it.
After correct placement of the cannula, this cannula can be connected with the three-way.
This needs to be, like before proceeding, you need to confirm that you are at the right place. Otherwise, you will be causing surgical emphysema or some other complication, and your purpose will be lost. So you need to confirm it. Placement has to be confirmed.
Same with the half, the syringe with the filled with the saline and aspiration bubble. When the free flow air is there with the bubble, then it is the you are in the right place. So connected with the three-way, and end of the three-way can be connected with the jet ventilation like this, and then you can start ventilating the patient by using the jet ventilator. If jet ventilator is not available, then what you can do? Then you can
one more point. When you are ventilating like this, always make sure that there is some part of the upper airway which is open. Exhalation has to be allowed, right? So if the patient is paralyzed or unconscious, then you may have to either put in a oropharyngeal or a nasopharyngeal airway, or you may have to hold the mask, and you should make sure that exhalations are effortless. That will help prevent rise of ETCO2, or it will minimize the trend of rise of ETCO2.
When the jet ventilator is not available, then you can make and ready. You can keep these assembly ready in the operation theatre. This is the three-way, and at the place of jet ventilator in the previous slide, you can put the plunger of 2 ml syringe and the adapter of ET tube. 7 number or 7.5 number will get fixed here, and this assembly can be fixed with the non-compliant tube and connected to the ventilator, and with the high flow oxygen push button, you can ventilate the patient at the rate of 1:4. 1 is the time for inspiration and 4 for the expiration. So what are the advantages of this technique? This technique is very simple. Okay, easy to master, and very few things are required. Everywhere, these things are available everywhere in the OT, in the ward, everywhere. ETCO2 monitoring can be done by the other end of the three-way. ETCO2 can be connected from here, and very few complications. This is a bedside procedure, and this is the only front of neck access technique for the children below the 12 years, because they have very small size of cricothyroid membrane. So the negotiating the tube would be difficult, and even you will negotiate, then the formation of strictures are very common in the future. And what are the disadvantages? Now you can easily guess what are the disadvantages. Is not a definitive way. Ultimately, you have to shift on some other definitive way, because you cannot ventilate the patient for. This is just a time buying technique. Rescue ventilation. You are just buying the time. Okay. One another. Bolo koi. Barotrauma, very good. And when you are ventilating the patient with such a narrower cannula, with such very high pressure would be required, then there are chances of barotrauma, surgical emphysema, and puncture of through puncture, esophageal puncture. Yes, posterior tracheal wall and esophageal puncture.
Such ventilation even can cause air embolism.
Yes.
Embolism.
Yes. And kinking is very common. One person have to stay with keeping the cannula in place, and still there are very high chances of kinking and malpositioning. And there are lack of standardization of transtracheal jet ventilation technique, which cannula should be used, what should be the oxygen source, what should be the driving pressure and jetting frequency. So everyone will do as per ki jo jisko jaise jam jaye वैसे कर लेगा.
Whatever situation is there, you need to see the chest inflates a little, the saturation improves, right? And you ventilate for least possible time and allow exhalation to occur. You just want to buy time, you need to maintain the SpO2 within reasonable limits so that the bradycardia does not occur and the vitals are maintained. You don't try to make 100%, you don't make the chest rise to the fullest. And you may increase the frequency rather than doing it in full. Okay.
Other commercially available cannulas. Here I am showing you two examples of the commercially available cannulas. One is the Melker Cook, which is over the guide wire, and another is without the guide wire. So this first one is the Melker Cook. This internal diameter is 5 mm. So this is a cricothyroidectomy set which is available for this particular purpose. Technique is similar to the cannula cricothyroidectomy technique which we have been gone through. So this is the set, and by this set now you can tell that what should be the technique. Please, one by one. What? First, position. Second, identify the cricothyroid membrane. Third, scalpel भी रखा हुआ है. Make a small incision and then needle and cannula. Then identify the location of correct placement. Identify the correct placement with a half-filled saline in the syringe. And when if the tube, this cannula is correctly placed, then remove the syringe and then thread the guide wire. After this, remove the cannula. Guide wire निकालो. Remove the cannula. This one is the sheath. This one is the sheath, which can be fixed in the cannula, and this whole assembly can be threaded over the guide wire. And once it is that you are satisfied that it is correctly placed, then remove the sheath with the guide wire. And the cannula will remain inside and inflate. You can inflate this also. नहीं इसमें बल्ब इसमें नहीं है वो with बल्ब वाले भी available होते हैं, but this is without the bulb. So you can ventilate after correcting the bag mass. Bag mass you can ventilate the patient with this cannula. So advantage, what is the advantage? This is the less time consuming, better ventilation because it is a wider growth than the 14 gauge cannula or 16 gauge cannula. And what would be the disadvantages? Disadvantages: availability, cost. These are nearly 6,000, 8,000, 10,000 cost of cannula, and the unfamiliarity with the several type of commercially available devices. So you should be familiar with these commercially available devices, then how we should use this. Another type is quick track type of cannula. There is no guide wire in this. So by doing this, you can, I think now you can tell me that how you will ventilate the patient with this. Same position, identify, and then okay, break. कहाँ तक जाओगे ब्रेक करके? Go up to this place. Go up to this place. Okay. Check with the syringe that you are at right place. If you are at correct place, then remove this safety lock. This is safety. This red one is the safety lock. This safety lock would be removed. Then go further. After a few millimeter, you will there will be audible clicked sound. Means now this sheath is covering the cannula. Okay, and when this click sound appears, then you can go further until this flange rests over the neck, and then remove the needle and connect it with the bag, and you can ventilate the patient. So advantage is it is available as complete set, and it does not require any dilator, any guide wire, etc. And this technique is simpler, fastest, single step, and controlled ventilation is possible because there is an inflatable balloon. So it can be connected with the breathing circuit easily. And same disadvantages, and this is not universally available, and training is required because you can deviate from the midline during insertion or during the breaking the cannula. Chances of injuries are little higher. Another is the scalpel cricothyroidectomy technique. This is the most preferred one by the difficult airway society. So very few equipments are required. Same. What are the steps? Hyperextend the neck, then identify the cricothyroid. Identify the cricothyroid. Then what next? After that, hold scalpel in your right hand. Hold scalpel in your right hand, and then make a transverse. And the cutting edge should be pointed towards you, operator. Okay. Once you have pricked the cricothyroid membrane, then rotate it to 90 degree. Yes, cutting it. Now cutting it towards the caudal side. At this point, swap your hands. Now hold this with the left hand and pull it towards you, towards your side. Hold the bougie with the right hand and negotiate the bougie with the through the incision side, and go 10 to 15 centimeter inside the trachea, and then remove this and railroad whatever number 6. Try with the 6 number. If number 6 is not possible, then use the smaller endotracheal tube or
tracheostomy tube. So what are the advantages of this technique? It can be performed everywhere because minimum equipments are required. Everywhere you can perform this. Ability to ventilate the patient and monitor the EtCO2. You can ventilate the patient for longer time, for 1 day, for 2 days. If the patient is okay, then remove the tube after. You can remove the tube afterward. So it provides unobstructed path for exhalation. So CO2 will come out easily, and insertion of cup tube provide protection against the aspiration. What are the disadvantages? Disadvantages are failure rates are quite high, and incorrect placements are reported. Excessive bleeding can happen, and air leak, and learning curve is little higher than the cannula techniques. If there is any like anatomical problems, landmarks are not very clearly visible, then you can go with the surgical cricothyroidectomy also. You can make an incision first and then identify the cricothyroid membrane, and once the cricothyroid membrane is identified, then go further with a blunt dissection. Again identify the cricothyroid membrane, and once you are confirmed that yes, this is the cricothyroid membrane, then make a step with the knife and use a dilator to dilate that space, and then insert a tracheostomy tube preferably. So this was all about the access from the cricothyroid membrane. And if you are having a little more time and you think that definitive airway ultimately would be required, like patient having quadriplegic, patient is quadriplegic, and you think that yes, this patient will require ventilation for a longer time. So if you are able to access with the cricothyroid membrane, even then ultimately you have to shift on the tracheostomy, and you are having time and you are having skill also. So this is also required. Then you can go for the directly go for the tracheostomy, despite of the cricothyroidectomy. So identification of landmark are just extend the neck, then make a line over cricoid, one line over the cricoid, lowest line for the sternal notch, and incision should be taken in the midline, in the middle of the both lines, upper line and the lower line, or 2 centimeter or 1 finger below the cricoid, or 2 finger above the sternum. Anything landmark can be taken. It should be between the first or second tracheal ring or the second or third tracheal ring. So same incision is made below the cricoid. And what is another important thing in tracheostomy? Always stay in the midline. Don't deviate from the midline, because midline plane is the avascular plane. Otherwise, there is no guarantee that any artery or vein will come into your way and the chaos will happen. So always stay in the midline. This is avascular plane. And another key point is don't cut any muscle, because these are the strap muscles, and these goes like this, okay, vertically. So just split these muscles. Split, retract, split, retract. Then you will find the tracheal fascia and the white shiny structure. Identify with the your finger, and then make an incision of appropriate size and to the tracheostomy tube. One more problem can happen during tracheostomy, that is the
thyroid, isthmus of the thyroid. It will come into your vision or surgical field. At this time, you should retract it upwards. Okay. This is thyroid isthmus. So it should be identified. Then a step should be made, and there are many type of labs. Somebody take the U, inverted U or plus type. So जो भी आपको पसंद हो and you are able to do it, or in emergency just put a step. Okay. So make a step. If tube is already there, endotracheal tube is already there, then it will come into your vision. So you will again make yourself sure that you are in right place. Then tracheostomy tube should be pulled upwards from your vision, and then you can put the tracheostomy tube. That was these were the steps of surgical tracheostomy, and next is the percutaneous dilatation tracheostomy, and we will not discuss in detail because we are having video of this, and now I think by looking this set, now you are able to identify the steps. So what would be the steps? What you will do first? Positioning. Then identify. Okay. Then marking. Okay. Marking. Identify में marking आ गया वैसे ना. Then confirmation हो गया. Then use the scalpel. Put the incision. Okay. Then put a cannula and put a cannula. Use syringe half filled with saline. Aspirate and okay. Then guide wire. Place the guide wire. Then guide wire के बाद इसमें से क्या डालोगे first? Which one? Which one? ये white वाला. ये वाला. सारे डायलेटर हैं. These all are dilators. These. ये सबसे पतला भी है, लंबा भी है. तो इसे डाल के this will remain there, है ना? This will remain there, and over this guide wire and this sheet, then the guide wire as per the Seldinger technique. Initially the lower bore, then higher bore, high bore, high bore, high bore, and once the size of stoma is appropriate, then thread the endotracheal tube over this. No, this depends on the skill. If you are skilled, then this is a hardly 3-4 minutes procedure. So if you are able to ventilate the patient, means partially ventilating the patient, then you can do it. So now steps देखने के बजाय वीडियो देख लेते हैं, पर राजकुमार वीडियो प्ले कर देना मुझे. So we will see two videos, one of percutaneous tracheostomy, another of percutaneous tracheostomy with the help of giggle forcer. 1.5 कहाँ से आया था पूजा तुम्हारा? इसमें तो फास्टेस्ट आ रहा है. अच्छा. The great perfusionist tracheostomy penetration of that that's what surgery. Appropriate patient monitoring includes ECG and dilated forceps. Dilate the trachea in a single step. The grooves located on the jaw are small packed along the curve. Included in the kit is a 40 procedure. The integrity of the This is the same.
Begin patient preparation by increasing the inspired oxygen concentration to 100%.
Oxygen, pre-oxygenate.
Placed under the patient's shoulders in order to hyperextend the patient's neck, elevating the larynx.
These both patients are intubated already.
The head should be positioned straight and in the midline position. The neck and operative area are cleaned with swab sticks containing iodine. It is essential to identify the relevant anatomical landmarks. Here, the sternal notch, cricoid, and thyroid cartilage are marked with a surgical marker. The fenestrated drape provided in the kit is then placed over the patient.
Thyroid, cricoid,
The
sternal
operative
notch.
sites for the tracheostomy tube insertion is generally between the first and second or second and third tracheal rings as seen on this longitudinal view of the trachea and is generally midway between the cricoid cartilage and the sternal notch. Local anesthetic is then injected into the skin and subcutaneous tissue at the operative site. A 1.5 to 2 centimeter skin incision is performed between the cricoid cartilage and the sternal notch. The incision may be horizontal or vertical and need not be larger than that required to pass the tracheostomy tube. At this stage, blunt dissection of the subcutaneous tissue should be performed using the mosquito forceps supplied in the kit. The dissection may be followed by finger palpation to determine the overall lie of the trachea and location of the tracheal rings. With the aid of a bronchoscope, position the
Bronchoscope is already there.
at the tip of the
So
endotracheal
I
tube.
choose this video so that
The
you can see bronchoscopic view also.
It's illuminated
What is
by the
happening
line
inside.
of the ET tube's distal end. The bronchoscopist withdraws the bronchoscope and ET tube as a single unit until trans illumination of the bronchoscope is seen clearly viewed in the surgical site. The local anesthesia fill syringe is attached to the 14-gauge needle cannula assembly, inserted in the midline and perpendicular to the trachea while aspirating. Stepping off the tracheal ring if necessary, a sudden loss of resistance followed by free bubbling of air confirms entry into the trachea. Bronchoscopic visualization confirms proper placement and helps prevent the needle from penetrating the posterior tracheal wall. The needle should pass between the first and second or second and third tracheal ring as illustrated. With the needle and syringe angled caudally, the cannula is advanced into the trachea and the needle and syringe are removed, leaving the cannula in place. Reconfirm the placement of the cannula by bronchoscopic visualization or by reattaching the fluid-filled syringe to the cannula and reconfirming the bubbling of air. After straightening the J-tip of the guide wire by withdrawing the wire into the red introducer, insert both the introducer and guide wire into the cannula and advance the guide wire into the trachea. The guide wire should pass easily without resistance. The guide wire introducer is then removed.
So this is very important. Guide wire should pass without any resistance.
In the trachea. Great care should be taken throughout the procedure to avoid kinking the guide wire.
This is very commonly happen, kinking of wire.
The guide wire moves freely in the trachea.
So you should pull out and pull in the guide wire several times. That this is freely moving.
To and fro in a gentle motion while in the incision and trachea, freeing up the soft tissues. The pre-dilator is then removed. With the dilating forceps in a locked position,
This is the Griggs
the forceps are threaded over the guide wire and advanced through the soft tissue until resistance is encountered at the tracheal wall. They are then opened and removed in the open position.
Guide wire can be threaded through this
of the soft pretracheal tissue. The next step is tracheal dilation. The dilating forceps are again locked and advanced over the guide wire. A loss of resistance is felt as the forceps penetrate the tracheal membrane. The forceps are then elevated in an upright position. In this position, the curved ends of the forceps are pointed caudally within the trachea. After confirming free movement of the guide wire, the forceps are then opened and removed in the open position. The force used in opening the forceps are applied laterally to the trachea and determines the eventual size of the stoma. Tracheal dilation is now completed, and insertion of the tracheostomy tube follows. The tracheostomy tube and obturator are threaded over the guide wire and inserted into the trachea. The obturator and guide wire are removed. The cuff is inflated.
Okay, now we can see another video also. Thank you. So this video was of 4 minutes and he was doing pretty comfortably. So by this time, if we are having command on this procedure, then we can perform it in the same time, 4 minutes, 5 minutes.
Step 1. Prior to insertion, the integrity of the tracheostomy tube cup and inflation system should be checked by fully inflating the tube cup. If satisfactory, fully deflate the cup, smoothing it with saline in the syringe may be used to inflate. Step 4. If not, full infiltration with ethyllidocaine rings and select the site for needle, guide wire, and endotracheal tube cup. While viewing through the bronchoscope, reposition the endotracheal tube so that it just below the vocal cords.
Pull out the tube.
Proper repositioning of
just distal to the vocal cord and inflate it here.
Filling the endotracheal tube with the needle cannula assembly. Hold the endotracheal tube in position, ensuring head and neck are positioned midline. Step 2. Insert the 14-gauge needle and cannula with attached saline
so that your bulb is not get punctured.
This reduces the likelihood of the guide wire being passed into the pharynx. Advance the needle and cannula
and avoid the rings to puncture.
Until a sudden loss
Puncture between the rings.
Followed by free bubbling of air.
If you encounter the resistance, just move your needle millimeters above or down.
Gentle in and out movement of the endotracheal tube will help determine if the endotracheal
so this
tube
is very important. Correct
If
placement.
such is the case, the needle will move up and down as the tube is moved in and out. In such cases, the needle and cannula should be removed and reinserted after the endotracheal tube has been withdrawn at least 2 centimeters. Once the needle and cannula have entered the trachea, they must be held immobile so that the tip does not drift out of the trachea, which will result in incorrect placement of the guide wire. Care must be exercised to ensure the needle, guide wire, guiding catheter, and dilator do not perforate the posterior tracheal wall, resulting in potentially life-threatening injury. Once the needle has been partially or completely withdrawn from the cannula, never reinsert it, as this could result in the cannula being cut and left in the trachea. Leaving the cannula in place, withdraw the needle and syringe. Connect the syringe to the cannula and withdraw air to reconfirm that the cannula is in the trachea. Remove the syringe. Step 3. Next, take the flexible guide wire and guide wire introducer and straighten the J-tip using the guide wire introducer. Insert the guide wire introducer into the plastic cannula and advance the guide wire until the first mark can be seen in the cannula and at the level of the skin. Great care should be taken throughout the procedure to avoid kinking the guide wire. Confirm the free movement of the guide wire by moving the guide wire, without resistance, in and out of the cannula prior to removal. As the guide wire will be used to guide components into the trachea, it is important to frequently check the free movement of the guide wire in and out of the components and trachea. Remove the guide wire introducer followed by the cannula. This leaves the flexible guide wire positioned in the trachea. Step 4.
Black mark.
Advance the lubricated 14-gauge pre-dilator over the guide wire through the soft tissues until resistance is felt on the tracheal wall. With a gentle twisting motion of the dilator, advance the dilator to penetrate the pretracheal tissue and anterior tracheal wall. Remove the dilator, leaving the guide wire in place, ensuring that the first mark on the guide wire is at the skin level. Step 5. Pass the long guiding catheter over the guide wire into the trachea in the direction of the arrow mark until the black safety stop on the guiding catheter is located at skin level. Align the proximal end of the guiding catheter with the proximal end mark on the guide wire to ensure correct insertion depth of the wire guiding catheter assembly. The next stage is tracheal dilation. Prior to insertion, immerse the distal end of the tapered dilator in sterile water or saline to activate the lubricious coating on the dilator. Step 6. Pass the dilator over the guiding catheter until it reaches the black stop. The proximal mark of the guiding catheter is just visible at the handle end of the tapered dilator. While stabilizing the guide wire and catheter assembly, insert and partially remove the tapered dilator several times in order to overdilate the trachea to a size appropriate for the tracheostomy tube. The dilator is marked with a 38 French gauge and a maximum insertion depth mark. The dilator should not be inserted beyond the maximum depth mark.
This single step dilator.
Not to pull the guide wire guiding catheter assembly out of the trachea when removing the tapered dilator.
Rhino. This is called rhino.
Reposition the guide wire guiding catheter assembly and remove the tapered dilator, leaving the guide wire guiding catheter assembly in the trachea. Air will exit through the tracheostomy stoma, confirming the correct placement of the dilator. Tracheal dilation is now complete. Step 7. Pass the lubricated tracheostomy tube loaded onto its lubricated introducer over the guide wire guiding catheter assembly into the trachea with a slight twisting motion.
Okay, thank you.
So basic ultrasound class has already done. Now, याद तो अभी क्लास So you have to know about the basic of ultrasound, basic about the probe, basic anatomy of the airway. You have to know before the airway ultrasound. So what will be the position of the patient? It's the same as the sleeping position we commonly use in the intubation. And these are the three views. sagittal, parasagittal, and the transverse view. We commonly take our probe in the three direction, three plane. One is the sagittal plane, is the midline sagittal plane. When we keep lateral to the sagittal plane is the parasagittal plane. When we keep our probe is the transverse from that longitudinal way. This is the transverse plane. So three type of plane we commonly use during the airway ultrasound. So about the basic appearance of the different part of the ultrasound, the different part of the airway, larynx, you have to know about before the procedure. You all know the larynx is commonly one bony part is the hyoid bone. The bone is appear as a hypoechoic in appearance with the hypoechoic shadow. You can you see here there is no bone. Okay, the cartilage, most of the cartilage are seen in the homogeneous hypoechoic in appearance. The muscles commonly seen as the hypoechoic heterogeneous in appearance. The glands, mostly you can see here the thyroid gland. It is mostly seen as the homogeneously hyperechoic in appearance. You can see here this is the tracheal cartilage, which is the hypoechoic in appearance. Just below the tracheal cartilage, it is the air mucosal interface, which is hyperechoic in appearance. You can see the air is the enemy of the ultrasound. So these all things you can see here just before the anterior part of the trachea are the artifacts. The most commonly artifacts we can commonly see are the comet artifacts and the reverberation artifacts. I will discuss about first is the anatomy of the different part of the airway, then the application of the ultrasound on the different part. So I will start from the upper part to the lower part. So airway is the superficial structure, or for the airway we commonly use the linear probe. But the tongue is only thing to we have commonly tongue is the only thing we use the curvilinear probe, because from the superficial the tongue is situated slightly deeper side. So we use commonly the curvilinear probe for the curvilinear probe for the tongue. Otherwise, for the whole airway, we commonly use the linear probe. So when we keep your probe in the sagittal plane, like this manner, you can find there is two type of shadow. It is a superior. It is the anterior surface, anterior side. This is the posterior side. This is the cephalic side. This is the caudal side. Caudal you can cephalic you can see the mental shadow, and here you can see the hyoid shadow. The between you can see here, this is the posterior anterior dorsal surface of the tongue. This is the ventral surface of the tongue, and you can see here the dorsal surface of the tongue is appearing slightly hyperechoic in nature. Okay. Then above the tongue, then hyoid bone. When we keep the probe over the hyoid bone, you can see hyoid bone is appears as a hyperechoic inverted U shape with the hypoechoic acoustic shadow. And you can see here, this is the hyoid bone. Just above this is the strap muscles. Okay, so this is the anterior side, this is the posterior side, this is the right side, this is left side. You have to orientate about the picture. This is the another, and this is the another picture. You can see here, same thing when we keep a program on a hyoid bone. You can see this is the hyoid, it is inverted V shape. Okay. And this is the strap muscle, this is the anterior part, in the posterior part. The better I explain it during the hands-on. And between the hyoid and third cartilage, the membrane is present, which is called thyroid membrane. It provides the window for to see the epiglottis. When we keep your probe over the thyroid membrane, you can see here the better view of the epiglottis. You can see here this is the anterior surface, anterior part, anterior side, posterior side, right and left. You can see here this is the epiglottis. Epiglottis is the cartilaginous part, which is the hypoechoic in nature. And just below the epiglottis, this is the hypoechoic AM interface. And just anterior to the epiglottis, this is the pre-epiglottic spurs, which is the hyperechoic in nature because of collagen tissues. Fibrotic tissues present just above the just anterior to the epiglottis, to which called the hyperechoic periglottic space. So what are the advantages of the the epiglottis hyoid bone? So we can identify. I will explain it later during the applications. So we measure from the by the caliper the distance from the epiglottis to skin to the epiglottis. So we can found it is the difficulty or non-difficulty during the laryngoscopy or here. So we can identify by these images. This is another picture we can see. This is the epiglottis with the hyperechoic in nature. From this is the anterior surface, this is the posterior surface, and right and left side there. You can see here we can measure the distance from the epiglottis to the skin area to identify the difficulty in the laryngoscopy. I will explain it later. Now when we keep the probe on the thyroid, so thyroid cartilage over the Adam's apple, so it will give, we can see here the epiglottis. When we put your probe over the thyroid cartilage, you can see here the thyroid is the hypoechoic V-shaped structure, and you can see here the vocal cord. Vocal cord is two types: the fast vocal cord and the true vocal cord. Fast vocal cord is situated slightly cephalic to the true vocal cord, and you can see the vocal cord is commonly seen as the hypoechoic, but the middle border of the vocal cord is hyperechoic because of the vocal cord. The middle border is more made of the vocal ligament. For better visualization of the vocal cord, you have to set the patient to make some noise like a, e. So you can better, the vocal cord is more prominent during the phonation. This is another picture of the vocal cord. You can see here there is a middle border is the hyperechoic and the vocal cord is hypoechoic in nature. The cricothyroid membrane. Between the thyroid cartilage and the cricoid cartilage, there is present the cricothyroid membrane. इतनी बात हो रही है cricothyroid membrane की. So what is the importance of the cricothyroid membrane? When we keep your probe in the sagittal plane, in the midline between the thyroid and the cricoid cartilage, you can find this type of image. You can see here, when you keep your probe, you can check the cartilage, thyroid cartilage in the hypoechoic nature, oval shape, cricoid is the hypoechoic in nature, oval shape, or between these, this is the cricothyroid membrane, or just below it the hyperechoic line is the air mucosal interface. What is the advantage of this? In the what is the advantage? Anybody? If you found any anticipated difficult airway or in obese patient, if you mark prior to any procedure the cricoid membrane by the dot or anything marker, so if you land up, Bhagwan kare aisa na ho, if you land up in the can't ventilate, can't intubate condition, so it will save your time to cricothyrotomy. In the obese patient or anticipate difficult airway, if you mark the cricothyroid membrane prior to any procedure, it will save your time, because this time is the crucial time. Then after the cricothyroid membrane, this is the when we keep your probe in the transverse manner on the cricoid. Then you can see here the cricoid is appear as a hypoechoic bump or hump appearance, like arc appearance. Okay, and just cricoid, you can see here the air mucosal interface. And when we keep the probe over the supraesternal notch, supraesternal area, just above the notch, you can see here, you can find the thyroid gland. Thyroid gland appears as a hyperechoic homogeneous in structure. You can see here. Or this is the tracheal line. Okay. And you can identify the esophagus by the airway. How? When we keep your probe in the midline and just move your probe just lateral to the in the left side, same at the supraesternal notch. So you can find that the esophagus just below the posterior lateral to the thyroid lobe of the left side of the thyroid lobe. You can find the inferior, just the esophagus. This is the esophagus, which is find the posterior lateral to the trachea, or just below the left thyroid lobe. It is a most multi-layered collagen structure. You can identify it by, you can ask the patient to swallow, or by the peristaltic movement you can identify the esophagus. So what is the advantage over here of the esophagus? Anybody? I will explain it later in applications. Now this is that when we keep your probe in the midline between the just below the cricoid cartilage, you can see here in the cricoid cartilage and the tracheal cartilage. You can see here, this is the hypoechoic big structure. Then you can find T1, T2, T3, T4. This is the tracheal cartilage. There appears a string of beads. Then after that, identify the basic. So what are the application of the ultrasound in the airway management? So we can check that, we can identify the pre-intubation. We can identify with the ultrasound how to identify the prediction of the difficult airway, how to estimate the ET tube size, and in the intubation, how to confirm it is a tracheal intubation, esophageal intubation, or we can identify the bronchial intubation even with the ultrasound. Or during the extubation, it will also help. And by the ultrasound, we use the ultrasound with the using for the vocal cord function in cricothyrotomy and percutaneous tracheostomy. We commonly use the ultrasound. So, how the ultrasound used to identify the difficult laryngoscopy or prediction of the difficult laryngoscopy by the ultrasound? By measuring the distance from the anterior surface to the hyoid bone. You can see by measuring the distance from the skin to head bone, skin to the epiglottis and the tongue thickness, we can assess the difficult laryngoscopy. If the distance from the skin to head bone is more than 1.7 centimeter, so it is the difficult laryngoscopy. If the distance from the skin to the thyroid epiglottis is more than 3.5 centimeter, so it may be the difficult laryngoscopy. Or if the tongue thickness is more than the 6.1 centimeter, it also helps to diagnose the prediction of the difficult intubation. These are the different studies in the prediction of the difficult airway by the USC parameters. So prediction of the tube size also in the pediatric age group, we can identify the tracheal ET tube by the help of the ultrasound. You can see here the transverse diameter at the subglottic region. You can when we measure the transverse diameter, it is equal to the outer diameter of the endotracheal tube. Or it by the different study they said it is the superior to the age base or height base formulas. The UC base measure, identify or the ET tube is better than the age base or height base formulas. You can also predict the size of the double lumen tube by the help of the ultrasound. By measuring the outer diameter of the trachea by the ultrasound, by predicting the diameter of the left main bronchus for selection of the double lumen tube. We can also select the double lumen tube with the help of the ultrasound. We can also confirm the tube with the help of the ultrasound, which is the tracheal intubation, esophageal intubation or endobronchial intubation. What is the gold standard method to confirm that tracheal intubation is? End-tidal capnography. So the advantage of the USC is for the capnography you have to ventilate the patient. But the advantage of the ultrasound, you can identify the esophageal intubation without the bag and mask ventilation. Or like if your tube is in the trachea, so when your tube is in the trachea, so the esophagus is collapsed. Or when your tube is in the esophagus, you can find the double track sign. That means your tube is in the esophagus. So the advantage of the ultrasound is without the ventilation, without the bag and mask, you withdraw your tube and reattempt. You can do reattempt with the help of the ultrasound. Otherwise, if with the capnography you have to ventilate the patient, or if your tube is in the esophagus, so if you ventilate the patient, if the patient is full stomach, then chances of aspiration is high. There is an indirect method you can also use to confirm the intubation. When the tube is in the trachea, the lung sliding sign is present. What is the lung sliding sign? Movement of the pleura with the respiration. When the tube is in the trachea, the both side of the pleura is the movement is present. The both side lung sliding sign is positive. Or when your tube is in the right side, the lung sliding sign is present in the right side but not in the left side. The beauty of the ultrasound is you can find the endobronchial intubation with the help of the ultrasound, but you can't predict the endobronchial intubation by the capillography.
If the patient is breathing spontaneously and however is having hypoventilation, you will have lung sliding positive on both sides, irrespective of place where the tracheal tube has been.
Same thing is the diaphragmatic movement. You can identify the tube. Some studies they conclude that the sensitivity or specificity of tracheal and confirmation of tracheal intubation is higher. Sensitivity and the specificity is at 95% with the if you use the ultrasound for confirmation of the tracheal intubation. And advantage of the ultrasound over the cricothyrotomy, I already said. If you end up in the life-saving condition of the can't intubate, can't ventilate condition, if we mark the cricothyroid membrane before any procedure, before the induction of the patient, so it will save your time during the emergency condition. In the percutaneous tracheostomy, the ultrasound is also helpful. By you can identify the tracheal ring. So most commonly percutaneous tracheostomy is done between the second to third tracheal ring. So you can identify or mark the first or second or third ring with the help of the ultrasound. Or even during the PCT, you can identify the blood vessels. Or even you can check the insertion of the needle path, or you can confirm your gyne is in the trachea or not by the help of ultrasound. You can also ultrasound is also helpful during the extubation. The ICU patient, mostly when we extubate patient, sometimes we have to re-intubate the patient. Why? Because of the long duration of the intubation, it causes the tracheal edema, laryngeal edema. So post extubation stridor is present or not, we can also predict by the ultrasound. So how can we predict this? You can see here. This is the air column width. When this air column width, when we deflate the tube, the air column width should be increased. Ideally, normally this is the around 4.5. Or after the deflection of the cuff, your width should be increased around 6.5 centimeter. Or if the width is not increasing after the deflation of the cuff, it means the chances of the post extubation stridor can be occur. It means the higher chances of stridor if the after deflection of the cuff is 4.5 mm, or less chances of stridor are then if the width is more than 6.4 mm. So these are the study they found that this is the air column width in the non-stridor patient is the 6.4 and in the stridor patient is the 4.5. This is the graph. This is the study in the published in the 2020. They are using the. This is the graph. They are using. This is the common. We are using the parameters for the difficult prediction of the difficult airway. Or this is the when we use the ultrasound parameters with the clinical parameters, so it increase the accuracy of assessment of the prediction of the difficult airway. So in the summarize, you can identify the ectothelial membrane by the help of this. You can identify the tracheal intubation. You can identify the esophageal intubation by the help of the ultrasound, or it improve the accuracy of the assessment of the difficult airway with the help of ultrasound if we use it with the normal clinical parameter of the difficult airway. Thank you.
For your very comprehensive and very enlightened talk on ultrasound for airway assessment and also uses of ultrasound for related issues. Today's airway workshop, this is the first station. This station is devoted for teaching students the skills of bag mask ventilation and insertion of supraglottic device insertion. For this, our teacher on this station is Dr. Kaushal Baghel. He is Assistant Professor of Anesthesia.
Use proper size mask. For adult female, we are regularly using 3 number mask. For adult male, 4 number. Or is overweight or obese, we use 5 number. 5. Okay. Then we have to learn about the grips. It's first of all basic grip is a C and E grip. With the thumb and index finger we make a C, and with the other 3 fingers we have to make E. It's a proper. We have to keep our fingers on bony prominence, not soft tissue. It can cause ischemia. If you we can further go for long period of time, it can ischemia. So
you use these two thumb and index finger to hold the mask tight after making the airway clear, right? And to keep it in place. These 3 fingers, the little finger behind the angle of mandible, the middle finger in the middle of the ramus of the mandible, and the ring finger palpating the pulse. So single-handed you are monitoring ventilation as well as cardiovascular. Now this is important. This is important that the chest expansion is visible. So for that you have to keep the airway clear. So neck is extended. In an unconscious patient, the tongue tends to fall backwards and that causes airway obstruction. Now if there is an airway obstruction and you ventilate, then the air you are blowing in is going to take the path of least resistance and this will go into the stomach. But when you do it correctly, when the airway is clear, you will see lungs will inflate, there will be no epigastric distension. Alright? Now this चलिए करके दिखाइए make it quick सभी airway maintain करिए yes give the proper position it will show you where is your चलिए ठीक है now ventilate it. There should be more chest expansion. Your grip has to improve. If one is not able to do single-handed, you can use double-handed grip like this and somebody who is helping you. This is our second station and this is devoted to use of lighted equipments and video laryngoscope to do the airway management. This station is being manned by our Associate Professor Dr. Namita Gupta. She is going to demonstrate how to use video laryngoscope. This is King's video laryngoscope.
King's video laryngoscope. Before inserting, we have to assemble it. It's a click sound is there after assembly. There is this button is there to on and off the camera. This is switch button on and off of the camera. 2 type of plates are there: channel plate and non-channel plate. We have to assemble this before insertion, but in the case of obese patient or the large chest, large breast, we can introduce the plate and then assemble it first. So the technique of insertion, you have to keep in the midline, open it. The tip should be placed in the ventricula.
And you can see it on the screen.
We can see
so
on
you
the
can
screen.
see it on the screen. So there is very little chance of a wrong incubation. Now the benefit of video laryngoscope is that you can use a video laryngoscope even with a lesser mouth opening. So you don't need 3 fingers. You can use it in those who are having 2 fingers. So lesser mouth opening. And then you can be sure of it. So it is useful in cases of difficult cases. Alright. This is the next patient for airway workshop. This is devoted to insertion of double lumen tubes. And for this, the faculty, teaching faculty is Dr. Pooja Mongia. She is assistant professor of anesthesiology in Mahatma Gandhi Medical College.
What is a DLT? Anybody? Double lumen tube. So, what is double lumen tube used for? What is double lumen tube?
It is used for surgery, certain thoracic surgery in which we require only one lung to function.
One lung.
Yes.
What are the indications?
So if we have to pneumatic abdominal carcinoma lung,
Infection of tumor of one lung.
Isolation of
one lung. Fine. So as we've already discussed in the previous class also, these are 2 DLTs, one is the left and the right. So these left and right DLTs are for the isolation of the left main bronchus and the right main bronchus. We'll quickly come on the procedure, how to I will demonstrate. After I describe that they have 2 cuffs, one is the tracheal and the bronchial cuff. So the tracheal cuff is kept in the main trachea and the bronchus cuff is kept in the desired bronchus, which is in which the DLT is to be placed. So as we know that we need to isolate one lung. So the left DLT is being commonly used for both the lung isolations. Why? Number 1, because left DLT is easier to insert, right? And in the right, this is the right side because this has a Murphy's eye to ventilate the right upper lobe. This has a left which is facing towards the left bronchus also.
So, you have this good, nice mannequin to demonstrate how to put in this left side here.
Yes, sir. I will be showing it through the fiber optic because we don't have the laryngoscope, but there are 2 techniques of putting it. So after
lubricate a little.
After lubricating the fiber optic, because we have to place in the mannequin, we place the DLT. We railroad the fiber optic, keep it straight so that it doesn't hook. We railroad the tube, and somebody should hold it. Please hold it.
In real life, when you use double lumen tubes, do you always start with using bronchoscope or do you? So
No.
Here in the mannequin you are demonstrating.
Yes, most commonly we do laryngoscopy and then we insert the bronchial tube and confirm via fiber optic. So as this tube will not go in the nostrils, so I am going to demonstrate the oral technique of putting the DLT. This lever should be kept in the left hand.
Please show it here on the screen. So what you are doing here
Yes,
will be visible on the screen.
Yes, sir.
Right?
Very much visible.
All of you can see it?
Yes,
Yes,
sir.
Okay.
1 second, sir. I'll just straighten it.
Now remember the views you were told earlier that at different places you have got different kind of appearance. Okay? Okay, you have lubricated well. So this is the epiglottis you saw, and just below the epiglottis you see the glottis, and you just have to negotiate the Now you see the tracheal rings
So this
and the
is
glottis is there.
yes. So these are the tracheal rings. I have crossed the epiglottis, the arytenoids, as you can see from these are the 2 arytenoids. After I'm doing the movement on the liver up and down, I enter inside the trachea, as you can see the tracheal rings, but I have to enter more positioning the liver. एक मिनट ट्यूब ऊपर से पकड़ना है क्या? I have to enter, look at the carina. See, this is a little difficult because mannequin has a lot of resistance.
In the next session, here we will be teaching our students the science and art of doing fiber optic awake intubation, fiber optic guided intubation, and this will be demonstrated and taught by our faculty, Professor Dr. Kalpana Verma. Demonstrating how to do fiber optic microscopy through all these
students. So this is registration for fiber optics. But I have been told that it is not fiber optic. There is a camera in the distal end of this, and so the fibers will not damage if you bend it or something. So image quality is also better with this fiberless flexible props. So first of all, what we have talked about, patient preparation, patient consent, counseling, patients explain their process to patient, and patient preparation, anesthesiology, anxiolytics, and local anesthetics,
in detail,
as we have talked about.
We are going to proceed and teach you how to
you know about this,
how to hold it.
In non-competitive, right? The liver should be facing. Okay. So liver acts as, like when you are pulling the liver upwards, then the tip will move downwards, and when you move it downwards, the tip will go upwards. Okay. So this is the suction, and you have to write the suction here. This is the working channel. You can inject the local anesthetic. As you go, you can spray the local anesthetic through this hole. Okay. So adequately lubricate the this bronchoscope and the patient nasal. First of all, we are going to do it.
Place yourself comfortably at the height so that you can hold it.
Nasal roll we are using it for. We have done lubrication and nasal airway. Then remove the nasal airway.
The nice mannequin, you can see that the lungs are there connected to bronchial tree. And she is entering from the nasal passage. And you are seeing the view here on the screen.
Can you see
clear?
this? Yes.
So,
what is this?
Can you identify where she is? At what point? Yeah, she is in turbinates. Okay. She is in turbinates. Then she will proceed ahead. Now the trick is that you should always keep in the middle of the lumen and do not go on the wall, right? And keep everything in the center of the screen. Now she is gradually proceeding ahead. Yes, Dr.
This is comma. Then when you pass through here, you will be able to see this. This soft pellet. Okay. This, and when you go beyond the soft pellet,
now you can see the tip of the epiglottis, right? This is the tip of the epiglottis. Okay. And soon below this you will see arytenoid cartilages and the glottis. So tip of the epiglottis, when the tip is not coming in your field of view, you can ask the patient to protrude the tongue out if he is conscious. And that is why when you do awake tracheal intubation, you should not make the patient so much doped by using sedatives that he doesn't fall. Now just below this you see very nice and clear view of glottis. This station is devoted to teaching our students the art of using ultrasound for assessing the airway. This will be demonstrated and taught by our Associate Professor Dr. Mangilal. Dr. Mangilal is going to demonstrate how to use ultrasound for airway assessment. Okay. Besides all other means. Right now we will be focusing on airway measures. So you have been mentioned all about the use of ultrasound in the lecture which preceded. And now you are going to get the hands-on opportunity. Please go ahead.
After the hyoid, we can see the thyroid membrane. Thyroid membrane is present between the hyoid and the thyroid cartilage. So thyroid membrane we can provide the window for the epiglottis.
So first you will start from here and
yes,
you will be showing.
You already showed the tongue.
You kindly show again so that. So you want to show the tongue first? For tongue, since it is a deeper structure, right, they are using curvilinear flow. Whereas for superficial structures, for cricothyroid membrane and for other distances, he will be using the linear flow. You know it well in the high frequency. So for tongue, this is one of the important predictors. Distance from skin to tongue is one of the important predictors of possible difficulty. In combination with your clinical examination and other USG indices, it can help you a lot in identifying possibility of a difficulty.
When you keep the probe in the parasagittal plane over there, just I freeze it, you can see the two type of shadow. The cephalically, this shadow is from the hyoid knee, mentum, and this shadow is from the hyoid bone. So between hyoid or mentum, you can see this is the tongue. This is the posterior dorsal surface of the tongue, which is attached with the hard palate. We can measure the thickness of the tongue to detect the anticipation of the difficult airway. If the thickness of the tongue is more than 6 cm, then it causes difficult laryngoscopy. So we can calibrate it by this.
You can measure it and
we can measure it. We can use.
Please show up and demonstrate other.
So the other parameters are the superficial. So we can use the linear probe. And this is the first we will check the hyoid bone. When we transfer using from the cephalic to slightly down, you can see that this is the hyoid.
Very good demonstration.
Just I freeze it. You can see this is the hyoid bone. This is the only bone in the larynx. You can see this is the hyperechoic area with the hypoacoustic center. You can see this is the strap muscles, and you can measure the distance from the hyoid bone to the skin. If it is more than 3.5 centimeter, it can detect the anticipated difficult laryngoscopy.
Can you demonstrate these stools, the cricothyroid?
Yes. We can use the cricothyroid
in the same position?
Yes.
Or we will extend a little more?
Yes.
Fine. You hold the...
We hold the probe in the parasagittal plane in the midline.
And here we will be teaching our students the art of doing front of the neck access by different techniques. So whenever there is a difficulty in ventilation and you cannot oxygenate a patient, how to revive and make the patient safe. This will be taught here by Dr. Ravindra Sisodiya. He is assistant professor of medicine. So they have already been briefed about how to do it, and here they are being provided an opportunity for hands-on training.
So we have access intraglottically, surgically. We can do it with the cannula. So we identify the cricothyroid membrane and we can go with the cannula and will identify that we are in the right place.
So it is the same way you do the laryngeal check and then you identify the correct position of cricothyroid membrane. And once you are sure, then you proceed ahead with the equipment. Before any procedure, you should assemble your equipment, check everything, okay?
And we can ventilate with this cannula.
How do you check the correct placement?
Correct placement is checked by the half-filled saline syringe and with the aspiration of the air. So it is the checking.
And how will you be ventilating?
We will ventilate this patient with a high pressure source like jet ventilation and the fresh gas flow which is available or oxygen flow which is available in our ventilators, so we can ventilate the patient with that. Alternatively, we can access with the vital hole cannula surgically. So we will identify the cricothyroid membrane. We will give a step by a small step by having the sharp end of knife towards
15 number plate?
Yeah. Okay. The step is given and then
when you rotate
it caudally.
Caudally is important, not cranially. Okay. He is giving caudally. Okay.
Then
rotating caudally.
I will swap my hand and this space is created, and through this space I will pass
this bougie.
The bougie. This bougie is passed, and over this bougie I will pass
this lubricated suitable size,
number 6 tracheostomy tube for endotracheal.
Now for emergency airway you usually use 6 size tube.
And I will remove the bougie and I will ventilate the patient through this tube. This percutaneous tracheostomy, which is a very important technique, and nowadays it is very popular technique. So this is a set which is provided by the company.
This belongs to this is Cook's
set.
This is Cook set. Okay. So this one is pretty expensive, otherwise, huh? This is the complete kit which comes with all these equipments.
Or these dilators and guide wire and knife.
So this is the Cook's kit for
with the rhino dilator.
With the rhino dilator. All the emergency departments and wherever airway management is being done, they need to have this. This one is the guide wire celebrated. These are these dilators and everything is
So between the first, second or second, third tracheal ring, I will pass my cannula, and again I will check the correct placement of cannula by the air.
So this is done at which level?
This is tracheal ring 1, 2 or 2, 3, between 1, 2 or 2.
So this is not being done at the level of cricothyroid. Cricothyroidectomy is for a very emergency action, right? To this Baghel little kind. And then for a more definitive airway management, we go for between the tracheal rings.
Then I will pass my guide wire through this cannula.
Now make sure that you do not damage the thyroid gland.
Yes. And this space will be dilated by the serial dilators now.
So guide wire is there and then you need to dilate it. Okay. Now using dilator causes least chance of bleeding. If you use a scalpel blade, there can be bleeding.
Least chance of bleeding, and
so these are serial dilators. So gradually more and more dilatation occurs. All this has to be done in quick succession, and then alternate means of providing oxygen should always be there. Right?
So I will dilate it properly. Now it is sufficiently dilated and stoma is created of sufficient size.
Now
then
one is to make sure that the guide wire doesn't come out. Otherwise you are going to lose the guide. This helps you railroad the equipment, tracheostomy to cuff.
This is the last part.
Last part or very important?
Very important. So now the stoma is of sufficient size, and through this stoma,
push it through.
With the guidance of guide wire, I will push this tube, and then I will remove the guide wire.
connect their oxygen source or I will mentally try to.